Today's date is September 8, 2021, and the time is 6:17 p.m. This will be the videotape deposition of Dr. Robert Albanese in the matter of Shirley Couch versus Creative Hospital, Hospice Care, Inc. et al. Would counsel present please identify themselves for the record?
This is James Potts here on behalf of Shirley Couch.
Sharonda Barnes on behalf of Dr. James Michael Shiver.
Tom Asiati on behalf of Homestead Hospice and its employees.
And Rolf Martin on behalf of Renee Bonner.
Thank you. Would the court reporter please proceed?
Before I proceed, I will ask counsel to agree on the record that there is no objection to this deposition officer administering a binding oath to the witness remotely. Please state your agreement on the record, beginning with plaintiff's counsel.
James Potts on behalf of plaintiff, agreed.
Sharonda Barnes, I agree.
Tom Asiati, I agree.
And Rolf Martin, I agree as well.
Right. Dr. Albanese, would you raise your right hand?
Yeah, can you hear me?
I can.
A little.
Do you swear the testimony you're about to give in this cause to be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Thank you.
Dr. Albanese, will you tell us your name, please?
My name is Robert Pasquale Albanese, and Junior, MD.
Yes, sir. And where do you live?
I live in Calistoga, California, and I work in Yountville, California.
And are you a licensed medical doctor?
I am.
And when I say medical doctor or physician, are those interchangeable, the same thing?
I believe so, in my mind.
All right. And how long have you continuously been a licensed medical doctor?
Over 30 years. Yeah, about 30 years, I guess.
And do you supervise nurses?
Yes, I do.
And have you supervised nurses continuously since you practiced medicine?
I believe so, yes.
Where do you work?
I work at the Veterans Home of Yountville, a home for veterans and their spouses, and I'm employed by the state of California.
Yes, sir. And you treat veterans?
I do, and their spouses, some of whom are not veterans.
All right. And what is your title there?
Physician and psychiatrist.
All right. And what does a physician and psychiatrist do there?
Well, what I do is I treat mental illnesses and neurocognitive disorders. So I treat diagnose and treat primarily depression, anxiety, schizophrenia, bipolar, and Alzheimer, and other diseases, other neurocognitive diseases.
Yes, sir. And have you also taught in medical schools?
I have. I've taught at a number of different medical schools.
And what medical schools have you taught?
I taught at the University of Virginia, the Medical University of South Carolina, the University of Washington in Seattle, and the Baylor College of Medicine in Texas.
Yes, sir. And when you taught at these medical schools, did you teach medical students?
I taught medical students, residents, junior faculty, and colleagues.
All right. And you taught, and what is a resident?
A resident is a licensed physician who is completing what we call graduate medical education. So they're doing on-the-job training.
Yes, sir. A physician in training, is that fair?
Yes, that's correct.
All right. And you also taught colleagues, other physicians like yourself?
Yes.
And did you teach medical students, residents, fellows, colleagues, other physicians about the proper use of the drugs at issue in this case, opioids, benzodiazepines, and antipsychotic drugs?
Yes, yes.
And have you overseen the care of hospice patients as a physician?
Yes, between 2008 and 2013, most of that time I was at the Boise VA and I was chief of medicine there, and I was responsible for long-term care unit that had hospice beds.
Yes, sir. And what is the chief of medicine?
Well, the chief of medicine is someone who oversees the clinical operations of primary care, inpatient medicine, the emergency room, the intensive care unit, and like the long-term care unit. So I'm the administrative leader of all of those. I was the administrative leader of all those operations.
Yes, sir. And did you have a hospice medical director answer to you?
Yes, I sure did. I actually recruited him.
All right. Did you employ that medical director for that hospice?
Yes.
And did you take into account that medical director's hospice experience?
Yes, he was board certified in hospice and palliative care medicine.
All right. Have you ever employed a physician as a hospice medical director that was neither board certified in hospice or palliative care, nor had any experience in a hospice setting?
No.
Would you do that?
No, not if, it's conceivable if they had experience, but no, I would not.
All right. And I'd like to take you back to, as of 2013, tell me what would be required to become board certified in hospice and palliative care.
Well, yeah, and up until 2012, you could do what was called the career path. So if somebody was actively practicing in hospice and palliative care, they could sit for the exam. They would have to make a declaration that they had been practicing in that field, and they could study for and sit for the exam. And if they passed it, they would be board certified. That stopped at the end of 2012. So after 2012, the only way to become board certified in hospice and palliative care medicine was to do a fellowship. So that would be a year-long training that would be incompatible with running a practice. It would be a full-time job, and it would be a huge reduction in salary because it's a training job.
Yes, sir. In addition to overseeing the care of hospice patients and your role as the chief of medicine, have you also cared for hospice patients directly?
Not as the primary caregiver, but I have covered for them, and I have been a general internist and a psychiatrist for those patients.
Yes, sir. And were you asked to consider the violations in medical care that put Shirley Couch into a drug overdose and a drug-induced coma that ultimately led to her admission at the Athens Regional Hospital?
Yes.
Objection. This is Rolf Martin.
And join.
And give an expert opinion regarding how the care offered by Dr. Shiver and the creative hospice nurses led to Mrs. Couch's drug-induced coma?
Yes.
Objection.
And can you tell us your expert conclusion about that?
Yeah, I felt that that the patient was an inappropriate patient for a hospice and palliative care program, and that her medical management was not appropriate.
All right. And before we get into your opinions, I'd like to talk to you about what makes you, what education, experience, and training that you've had makes you an expert in this particular kind of case.
Well, so as an internist and a psychiatrist, I have to be an expert on the medical and psychiatric complications of using psychoactive substances. For example, opioids, benzodiazepines, and antipsychotics. I have a Suboxone exemption from the DEA. It's a special DEA number you have to treat opioid addicts with Suboxone. You can also use Suboxone to treat chronic pain. So I've worked in inpatient, outpatient settings in both internal medicine and psychiatry, and have had to be well versed on the management of pain, anxiety, and psychosis in general medical settings.
Yes, sir. Are you board certified in both internal medicine and psychiatry?
Yes, I am.
And you've practiced as an internal medicine specialist as well as a psychiatrist since the 90s, is that right?
Well, since 93. I don't practice internal medicine directly now. I do predominantly psychiatry.
Yes, sir.
Although I do give the people who consult me some advice on the management of blood pressure, allergies, and things like that.
Yes, sir.
So I do practice sort of in a consultative setting. But
And have you won awards related to psychiatry and medicine?
yes, I have. I've had a dozen or so awards, mostly for teaching and service. I got 3 golden apples at the Medical University of South Carolina between, I think it was 2006, 2007, and 2008, those are from the medical students, I believe, and I've had residency teaching awards as well. And then in 2002, I was Physician of the Year at the Ralph H. Johnson VA Medical Center in Charleston, South Carolina.
Yes, sir. And have you completed grand rounds?
Yes, I've done, I think, approximately 70 academic presentations in different academic settings in Virginia, North Carolina, South Carolina, Florida, Texas, Idaho, and even on this campus. I've done presentations here at the Vets Home that were broadcast to other veterans homes. We have 8 Vets Homes in California.
Yes, sir. And have you also been the principal investigator for drug studies?
Yeah, I was principal investigator on one for post-traumatic stress and one for bipolar disorder, and I also supervised a resident on one that had to do with weight gain and schizophrenia.
Yes, sir. And do you also have medical publications?
Yeah, I have, 7 or so academic publications, including a textbook I co-authored on called Primary Care Medicine for Specialists and Non-Specialists, a Practitioner's Guide.
All right. And do any of your medical publications also deal with the proper prescription and administration of drugs, the ones included here, opioids, benzodiazepines, and antipsychotics?
Yeah, we touched on that in our textbook. I did a chapter on cardiovascular disease in patients with substance use disorders. Those are 2 that I can think of right off.
Have you also been on medical committees, including pharmacy and therapeutics?
Yes, I've been on P&T committees, executive committees. I even was on some committees at the VISN level when I was in Idaho. I was VIS and DEA. So that was, I don't want to get into that too much detail. But yeah, I've been on a number of committees, yes, including a P&T committee.
Yes, sir. And do you also hold a DEA, a drug enforcement agency license?
Yeah, as I said, I have the regular DEA number, but I also have a special DEA number for Suboxone treatment.
And Suboxone is used to treat what?
It's used to treat opioid addiction, but it can also be used to treat pain.
All right. And where are you licensed to practice medicine?
I'm currently licensed in California and Virginia. I've been continuously licensed in Virginia since residency. I've also been licensed in South Carolina and Idaho, and I had a provisional what's called a faculty license in Texas.
That was when you were teaching at Baylor Medical School?
Yeah, that's right.
All right. Now, in addition to being a licensed medical doctor, you're board certified in internal medicine and psychiatry. What are these specialties, starting with internal medicine?
Well, internal medicine is, I think, the closest thing to what most people think of when they think of a doctor. These are doctors who learn how organ systems function,
Yes, sir.
and their primary job is thinking about diseases and making diagnoses, making accurate diagnoses. So they become experts in the function of the lungs, the heart, the pancreas, the liver, and they feed into those subspecialties. So like an internist, the only way to become a cardiologist is to become an internist first. The only way to become a gastroenterologist is to be an internist first. So they're primarily cognitive. In other words, they primarily use mental reasoning and evidence to make diagnoses and to make treatments. They, as they become subspecialists, they can become procedural, like cardiologists can be procedural and gastroenterologists can do procedures. But internal medicine is the study of the diseases of adults.
Yes, sir. And what was required for you to become board certified in internal medicine?
I had to complete 22 months of approved internal medicine rotations, 22 months or more. And then I had to sit for the exam. And I've recertified 2 times. So I've been board certified in internal medicine for 30 years.
All right. And you're also board certified in psychiatry.
That's correct.
And what is a board certification in psychiatry?
Well, you have to, as with internal medicine, you have to complete a minimum number of months of training in a ACGME recognized program. And then you have to take and pass the board exam. And I've been continuously board certified. I've recertified twice in psychiatry for almost 30 years.
And that was, so you did a 5-year combined residency, is that right?
That's right. It makes you, some things overlap between internal medicine and psychiatry. So if you do a neurology rotation, for example, that counts for both.
Yes,
So I did like 2 neurology rotations and so forth. So, so it's possible in 5 years to meet the board eligibility requirements for both.
And your combined residency program at the University of Virginia was 5 years, is that?
5 years, yes.
All right. And have you continuously been board certified?
Yes, ever since 93 and 95 respectively in medicine and psychiatry.
And what is required for you to remain continuously board certified in both internal medicine and psychiatry?
So until the last few years, it was just you would study and take the exam every 10 years, the recertification exam. More recently, they've added maintenance of certification activities. So you have to document continuing medical education and do some approved courses. And then you still have to you study for and take the exam.
All right. And I'd like to talk with you briefly about your education, training, and experience, starting with your education. When did you receive your Bachelor of Arts degree?
Let's see, I think that was in 1983.
Yes, sir. And where was that?
That was at East Carolina University.
Yep. And did you do any additional study?
I did a year of non-degree study, graduate study in cell biology.
Yes, sir. And then you went on to medical school?
That's correct, starting in 1984.
And where did you attend medical school?
East Carolina University School of Medicine. It's part of the University of North Carolina system.
Yes, sir.
And now it's called Brody School of Medicine at East Carolina University.
And then you went on to the University of Virginia for 5 years.
That's where I did my residency. my 5-year residency. And I was chief resident in psychiatry my last year.
All right. And do you hold any fellowships?
I was board certified in psychosomatic medicine for 10 years between 2008 and 2018. But because of the increasing cost, I elected to let that lapse.
Yes, sir.
So I was triple boarded for 10 years. That, by the way, has changed its name to consultation liaison psychiatry.
And are you a fellow with the American Medical Association?
I'm a fellow of the American College of Physicians. FACP is, I put that after my name, after MD. And that's an honorific position within the American College of Physicians, which is, I think, the largest medical organization in the country. It's internists and internal medicine subspecialists.
Yes, sir.
And I was nominated for fellowship and elected for fellowship by the committee. So I'm a fellow of the American College of Physicians.
Yes, sir. And that's what the FACP stands for?
Right, that's what that stands for.
Yes, sir. And you mentioned earlier faculty appointments. Would you list for us briefly your faculty appointments?
Yeah, I was an instructor at the University of Virginia, and then I moved to South Carolina, and I was an assistant professor at the Medical University of South Carolina, and then eventually became an associate professor. Then I moved to Idaho, where I became a clinical associate professor at the University of Washington. And then, let's see, where did I go from there? Then I went to Florida, and I didn't have a faculty appointment there. But then when I moved to Texas, I was an associate professor at the Baylor College of Medicine for the 3 years I was there.
Yes, sir. And do you also, I'd like to talk with you about your academic presentations.
Yes.
Have you done academic presentations?
Yes, I've done, I think, I don't know the exact number, I think about 70 different presentations at grand rounds and at national meetings, regional and national meetings of internal medicine and psychiatric meetings. I've done a large number of presentations in that setting.
And what is an academic presentation? And what is that setting?
An academic presentation is a presentation that you do to your peers. So it's other physicians and subspecialists. So it's more difficult than, it's more heavily scrutinized than, let's say, doing a talk for the Rotary Club, and I've done those kinds of things too, but here you get asked very pointed questions. An academic presentation I would define as in an academic setting like a university medical school or a national meeting, like the Association of Medicine and Psychiatry annual meeting, the Southern Medical Association annual meeting, and so forth.
And you also treat opioid addiction?
I do. I treat it with the Suboxone, and I've treated opioid overdose and opioid withdrawal. Did you hear me?
Yes, sir.
Oh, okay.
And you've also written peer-reviewed publications?
Yes, just a handful, but I think, a couple of a textbook chapter, and a number of publications about various things, case reports. For example, a patient whose hair fell out when they were taking Prozac, another patient who took an overdose of a medication, and it didn't produce a cardiac toxicity that we thought would happen. Anyway, that kind of thing.
All right. And when you taught medical students, residents, fellows, colleagues, other physicians at various medical schools, you taught about opioids and how to treat opioid disorders, benzodiazepines, and antipsychotics, including the proper reasons for prescribing those and the administration and monitoring of patients on those drugs.
Yes,
You've also treated patients on opioids, benzodiazepines, or antipsychotics,
yes, I have.
and you've prescribed opioids.
Well, now I don't prescribe opioids to treat pain. The only opioid I prescribe personally is the Suboxone. So that's a maintenance therapy for people with opioid addiction. Like I said, we can use it for pain as well. But I do treat patients with benzodiazepines, although, I try to, use as little as possible. And I do use a lot of antipsychotics.
And if you find an opioid or a benzodiazepine or an antipsychotic drug clinically appropriate, you can prescribe that drug.
Yes.
And have you ever diagnosed and treated drug overdoses, including drug overdoses caused by either opioids or benzodiazepines or antipsychotics or any combination of those?
Yes, I have.
I'd like to talk with you about Shirley Couch. And before we get to that, I'd like to offer you as an expert in this case. First of all, did you review the medical record involved in Shirley Couch's case?
Yes.
And that's the patient in this case, Shirley Couch, right?
Yes.
And did you rely on certified copies of her hospice records for Shirley Couch in June of 2017?
Yes.
And formulating your opinion?
Yes, I did.
And also the Athens Regional Medical Center records for Shirley Couch for June and July of 2017?
Yes, yes.
And you also reviewed and relied on Dr. Park's records for Shirley Couch?
I believe so, yes. I know yes, I did.
And also Shirley Couch's pharmacy records, including CVS records from June of 2017?
Yes.
And also discovery in this case, Couch v. Homestead et al., including the defendant's depositions, James Shiver, Renee Bonner, Tracy Sorrow, Mary Pippin, Teresa Allen, Christy Fowler, Rachel McKnight, Ashley Mercer, Shirley Couch, and Paula Stuchel.
Yeah.
You read those depositions?
Yes.
And you've also reviewed the exhibits to those depositions?
Yes.
And the non-defendant case depositions of I believe there were EMTs and a hospice employee, is that right?
Yep. Yep.
And the deposition exhibits to those depositions?
Yes.
And the GBI investigation involving Renee Bonner?
Yes, I did.
GBI investigation exhibits?
Yep.
DEA publications, photographs, including 2 photographs showing how little fentanyl it could take to kill an adult?
Yes.
The portions of the criminal trial transcripts from Renee Bonner's prosecution?
Objection.
Yes.
Yes.
And Renee criminal trial transcripts. Also the Shirley Couch's cardio clearance from March 23rd, 2017.
Yes.
and Shirley Couch's neurology clearance for April 6, 2017?
Yes,
And is it your understanding those clearances were for a knee surgery for Shirley Couch that was to take place in April? Is that right?
that's my understanding.
And did you also have occasion to speak to Shirley Couch?
I did.
All right, I'd like to talk to you now about the drugs that were prescribed to Shirley Couch and administered back in June of 2017. And those drugs include 4 opioids, 2 benzodiazepines, and an antipsychotic drug. Is that right?
Yep, that's correct.
Are each of those 4 opioids, 2 benzodiazepines, and that antipsychotic drug, and by the 4 opioids, I mean morphine sulfate, fentanyl, hydrocodone, and tramadol. And by the 2 benzodiazepines, I mean Ativan and Valium, also known as diazepam and lorazepam. And by the antipsychotic drug, I'm talking about haloperidol, also known as Haldol. Is that all right? And are each of these drugs that Dr. Shiver prescribed and that were administered to Shirley Couch in June of 2017 dangerous?
They can all be very dangerous. Yes, they can. They can all be dangerous.
All right. And based on your review of the records in this case, was there any medical reason for the prescription or administration of opioids to Shirley Couch while she was in the care of Homestead Hospice in June of 2017?
I don't believe that there was a medical diagnosis that warranted the use of opioids.
All right. And was it below the standard of care for Dr. Shiver to prescribe to Shirley Couch in June of 27 those 4 opioids, 2 benzodiazepines, and that antipsychotic drug?
I believe that's correct, yes.
And can you say that to a reasonable degree of medical certainty?
Absolute, I'm very certain. Absolutely.
And was it also below the standard of nursing care for the Homestead Hospice nurses to administer those opioids that were prescribed by Dr. Shiver for Shirley Couch in June of 2017?
Yes.
Objection, lack of foundation, qualifications, but you can answer.
Let me answer.
Yes, I believe it was.
Yep. And can you state that to a reasonable degree of medical certainty?
Yes, I'm absolutely certain.
And to a reasonable degree of medical certainty, did Dr. Shiver's prescription of those 4 opioids, 2 benzodiazepines, and the antipsychotic drug, and Homestead Hospice nurses and Renee Bonner's administration of those drugs cause Shirley Couch's drug overdose, drug-induced coma, and her admission to Athens Regional Medical Center?
Without a doubt.
Objection.
You may answer.
Without a doubt, yes.
All right. And well, what's the basis of your objection, gentlemen?
Foundation, qualifications, and it's also a compound question.
Compound as well as an incomplete and inaccurate hypothetical. You have not laid the foundation for the hypothetical.
All right. Dr. Albanese, will was it below the standard of care for Dr. Shiver to prescribe morphine sulfate, as you saw in the record, to Shirley Couch in June of 2017?
Yes,
And that's to a reasonable degree of medical certainty?
yes, absolutely.
Was it also below the standard of care for Dr. Shiver to prescribe to Shirley Couch in June of 2017 fentanyl?
Yes,
And you can say that to a reasonable degree of medical certainty.
yes, absolutely.
Beyond that, how certain are you?
I'm absolutely certain.
And can you also state to a reasonable degree of medical certainty that it was below the standard of care for Dr. Shiver to prescribe tramadol to Shirley Couch in June of 2017?
So it's a very weak opioid. I think the risk-benefit ratio, if that's the only thing she was being prescribed, would, with very limited use, be justifiable. The other opioids, no.
And can you state to a reasonable degree of medical certainty that it was below the standard of care for Dr. Shiver to prescribe hydrocodone, as you saw in the medical records that you reviewed, to Shirley Couch in June of 2017?
Yes.
And to a reasonable degree of medical certainty, did Dr. Shiver's prescription of these 4 opioids, morphine sulfate, fentanyl, hydrocodone, and tramadol, cause Shirley Couch's drug-induced coma and her admission to Athens Regional Medical Center?
Objection. Join.
You may answer.
So I think especially in combination, it's possible that those alone would have been, those alone would certainly have been likely to cause overdose at those dosages. She was on other medications that were also likely to contribute.
And by likely, do you mean more likely than not and to a reasonable degree of medical certainty?
Absolutely, yes.
Join.
And did Dr. Shiver's prescription of morphine sulfate to Shirley Couch in June 2017 contribute to her drug overdose and her drug-induced coma?
Yes.
Objection.
You may
Same
answer.
objection.
Join.
Yes.
And is that to a reasonable degree of medical certainty?
Yes, it is.
And did Dr. Shiver's prescription of fentanyl to Shirley Couch in June of 2017 also contribute to or cause her drug overdose and drug-induced coma?
Yes.
Objection.
Join.
And can you state that to a reasonable degree of medical certainty?
Yes, absolutely.
And to a reasonable degree of medical certainty, did Dr. Shiver's prescription of hydrocodone to Shirley Couch in June 2017 contribute to or cause her drug overdose and drug-induced coma that caused her to be transported to Athens Regional Medical Center?
Yes.
Objection.
Join.
And can you state that to a reasonable degree of medical certainty?
Yes, absolutely.
Beyond that, how certain are you?
Absolutely, sir.
All right. And now, did the Renee Bonner's administration of morphine sulfate to Shirley Couch in June of 2017 contribute to or cause her drug overdose?
Yes.
Can you say that to a reasonable degree of medical certainty?
Yes, absolutely.
Beyond that, how certain are you?
Absolutely, sir.
Did Renee Bonner's administration of fentanyl to Shirley Couch contribute to or cause her drug overdose and drug-induced coma?
Yes.
Objection.
Can you state that to a reasonable degree of medical certainty?
Yes.
Did Renee Bonner's administration of fentanyl contribute to or cause Shirley Couch's drug-induced coma?
Yes.
Objection.
Yes.
Did Renee Bonner's administration of morphine sulfate contribute to Shirley Couch's suffering a drug-induced coma?
Yes,
Can you
Objection.
state that to a reasonable degree of medical certainty?
yes,
Beyond that, how certain are you?
absolutely, sir.
All right. Now, based on your review of the records in this case, the investigation that you shared with us earlier, was there any reason for Dr. Shiver to prescribe 2 benzodiazepines to Shirley Couch in June of 2017?
No,
Were either benzodiazepine clinically indicated?
no, I saw no clinical indication.
Was it below the standard of care for Dr. Shiver to administer either benzodiazepine to Shirley Couch in June 2017?
Objection. James, can I just have a standing objection? I don't think he's qualified to offer opinions on the standard of care for Dr. Shiver based upon the qualifications that you set forth so far. So instead of objecting to every question, I'm happy to just have a standing objection on that basis, or I'm happy to continue objecting.
I'll join.
Yeah, no, you'll have to make the objections.
Okay, I will object then. But that is the basis of my objection.
All right. What was it? Would you read back the question, please, Madam Court Reporter?
Question, was it below the standard of care for Dr. Shiver to administer either benzodiazepine to Shirley Couch in June 2017?
Objection.
You may answer.
Yes,
And can you say that to a reasonable, state that to a reasonable degree of medical certainty?
yes,
Objection.
Beyond that, how certain are you?
Objection.
absolutely.
Do you have training in the prescription of benzodiazepines?
Yes,
Do you have training in the prescribing Ativan?
yes,
Do you have training in prescribing Valium?
yes,
Do you have experience prescribing Valium?
yes,
Do you have experience prescribing Ativan?
I do, yes.
And have you also taught medical students what's necessary to prescribe Ativan?
Yes,
Have you also taught medical students what's necessary to prescribe Valium?
yes,
Have you also taught other physicians what's necessary to prescribe Ativan
yes,
and what's necessary to prescribe Valium?
yes,
Have you also overseen nurses and they're administering Valium and Ativan?
yes,
Have you also taught nurses the proper administration of Ativan and Valium?
I don't know that I've ever, case by case, sometimes I'll say to the nurse, this is what you do in this case, but I don't, I have taught nurses in a structured setting, but it's been quite a long time. So,
All right. But you have continuously overseen nurses administer Ativan and Valium.
yes,
And you have education, training, and experience that qualifies you to prescribe Ativan and Valium.
yes,
You have the education, training, and experience to know what Ativan and Valium are for.
yes,
You know what the contraindications are.
yes,
You know what the potential adverse effects are.
yes,
Was there any clinical reason for Dr. Shiver to prescribe Ativan to Shirley Couch in June 2017?
Objection.
No, I did not see a clinical indication for that in the documents that I reviewed.
All right. And was it below the standard of care for Dr. Shiver to prescribe Ativan to Shirley Couch in June 2017?
Objection.
You may answer.
Yes,
And can you state that to a reasonable degree of medical certainty?
yes.
Objection.
Beyond that, how certain are you?
Objection.
Very, absolutely.
All right. And was it also below the standard of care for the nurses to administer Ativan to Shirley Couch in June of 2017?
I believe so.
And was it also below the standard of care for the nurses to administer Valium to Shirley Couch in June
Objection.
2017? You may answer.
Yes,
And to a reasonable degree of medical certainty, did the prescribing and administering Ativan contribute to Shirley Couch's drug-induced coma?
Objection.
You may answer.
yes,
And the sequelae, including her admission to Athens Regional Medical
Yes.
Center? And to a reasonable degree of medical certainty, did Dr. Shiver's prescribing and the nurses administering Valium contribute to Shirley Couch's drug-induced coma and the sequelae, including her admission to Athens Regional Medical Center?
yes,
Objection.
Yes.
And did Renee Bonner's administration of Ativan contribute to Shirley Couch's drug-induced coma?
Objection.
yes,
And did Renee Bonner's administration of Valium to Shirley Couch in June 2017 contribute to her drug-induced coma?
Objection.
You may answer.
yes,
And can you state that to a reasonable degree of medical certainty?
yes,
And are all your opinions that you share with us today to a reasonable degree of medical certainty?
yes, they are.
And beyond that, how certain are you?
I would say absolutely.
All right. And in addition to the opioids and the benzodiazepines, there was also an antipsychotic drug. Is that right?
Yes, haloperidol.
And have you ever prescribed haloperidol?
Yes, I have many times.
Have you taught medical students how to prescribe haloperidol?
Yes,
Have you also taught residents, fellows, colleagues, other physicians how to
Yes.
prescribe, when to prescribe Paridol?
yes,
And was it below the standard of care for Dr. Shiver to prescribe haloperidol, also known as Haldol, to Shirley Couch in June 2017?
Objection.
You may answer.
yes,
And can you state that to a reasonable degree of medical certainty?
yes,
Beyond that, how
Objection.
certain are you?
absolutely certain.
And can you state to a reasonable degree of medical certainty whether Dr. Shiver's prescribing Haldol to Shirley Couch in June of 2017 contributed to and caused her drug-induced coma and the sequelae, including her admission to Athens Regional Hospital?
Yes,
Objection.
Join.
yes,
I'd like to talk to you now about the 4 opioid drugs that were prescribed to and administered to Shirley Couch in June of 2017. Now, one of those opioids is morphine sulfate, is that right?
Yes.
And the morphine sulfate, according to the medical records, was initially prescribed at 0.25 to 1 milliliter every 2 hours, is that right?
That's correct.
And then on, was it June 23rd, I believe, Dr. Shiver increased the dose to 0.25 to 1 milliliter every hour. Is that right?
Objection, mistakes evidence.
Pleading as well.
You may answer.
That's how I recall it, yes.
Let's see. I'll show you what we'll mark as Exhibit 2 to your deposition. I'm going to show you what we'll mark as Exhibit 1 to your deposition, which is a verbal order by Dr. James M. Shiver, MD, and it's dated June 24, 2017 at 15:02 EDT. Do you see that?
Yes,
And is this one of the records that you reviewed?
yes.
And according to this verbal order, when did Dr. James Michael Shiver prescribe morphine 0.25 to 1 milliliter by mouth every hour, PRN pain, SOB, which presumably stands for shortness of breath, read back and confirmed, start date 6/24/2017.
Yes, 6/24/2017, 15:02.
Yes, sir. And where it reads here, 0.25 to 1 milliliters by mouth every hour, PRN pain, shortness of breath. Were you able to determine what 1 milliliter of morphine, how many milligrams of morphine that 1 milliliter contained?
My understanding is that 1 milliliter, I think it was 20 milligrams per ml.
Yes, sir.
So 0.5 would have been 5 milligrams, and 1 ml would have been 20 milligrams.
All right, so looking at this verbal order, the morphine 0.25 to 1 milliliters, which was, what does that mean where it says? .25 to 1 milliliters. If it's 20 milligrams per milliliter, 0.25 times 20 is how much?
5.
All right, and so that's 5 to 20 milligrams of morphine every hour. Is that what that verbal order indicates?
That's what it says to me.
Objection,
All right, well, that's the way it reads. Is that right?
Yes.
same objection.
And if you prescribe 5 to 20 milligrams of morphine per hour for 24 hours, how do you figure out what the maximum dose that can be given a patient under that verbal order by Dr. Shiver is?
Objection, that misstates the order and is an incomplete hypothetical, or actually an incorrect hypothetical.
Enjoin.
You may answer, Dr. Albanese.
So, if the patient was getting the maximum amount, so that would be 20 milligrams per hour, that patient would be getting over 400 milligrams of morphine.
Up to 480 in a 24-hour period, is that right?
That's right.
And you recall whether Shirley Couch also had a fentanyl patch on the 24th?
I believe she did.
And what was the dose of the fentanyl patch that Dr. Shiver prescribed for Shirley Couch in June 2017?
It was 50 micrograms, 50.
And a 50 microgram fentanyl patch, how much morphine or morphine equivalent is being delivered to that patient every hour?
Per hour, per day, it would be 120 milligrams of morphine per day.
All right. So in addition to the 480 that Dr. Shiver prescribed by his verbal order on the 24th with a morphine sulfate, the 120 milligrams of morphine equivalent per day by the fentanyl patch would be in addition to that? Is that how that works?
Objection.
You may answer.
Yes.
So that would be a total, if she got the 1 milliliter every hour with the fentanyl patch, just those two drugs alone, that would be, what, 600 milligrams of morphine?
Yes. 600 milligrams of morphine.
And I'd like to talk to you for a moment about what a normal starting dose for morphine would be. What is that you prescribe morphine?
I have prescribed morphine, yes.
You've taught medical students how to prescribe morphine.
Yes, I have.
You've taught residents, fellows, colleagues, other experienced physicians how to prescribe morphine.
Yes, I have, in some years ago, yes.
And you've also, your education, training, and experience, you've studied, learned, and taught the proper reasons to and not to prescribe morphine.
Yes.
And are you also familiar with the administration of morphine?
Yes.
And have you also taught medical students, residents, fellows, and other experienced physicians that?
Yes.
And what would be a normal starting dose for a patient that's not opioid tolerant?
A lot has to do with the volume of distribution, but I would say 10 to 20 milligrams a day.
All right. And was Shirley Couch an opioid tolerant patient in June of 2017?
Not as far as I can tell. No, she wasn't.
And how do you know that Shirley Couch was not an opioid tolerant patient in June of 2017?
Well, I didn't see a lot of documentation that she had been exposed to a lot of potent opioid. And then I asked her, actually, when I talked to her, did she take many opioids? And she said that she did not, that she managed her pain with acetaminophen or Tylenol, and that she had trouble tolerating the nausea caused by opioids.
All right. So you would consider...
Hold on. I move to strike the response as incorporating or trying to incorporate an out-of-court statement from another witness that was not under oath, and so it's hearsay.
Join.
So I'm objecting to the foundation laid for your question, or the lack of foundation.
Join.
Would you read back the question, please, Madam Court Reporter?
Question, how do you know that Shirley Couch was not an opioid tolerant patient in June of 2017?
And do you agree that Shirley Couch was not an opioid tolerant patient in June 2017?
Yes, because from the information I reviewed, she had only had trivial exposure to opioid the months prior to her overdose, or to her starting to get going into hospice, let's say. And I think it was 5 milligrams of morphine she'd gotten in that month, and then a couple of tramadols.
All right. And you would also agree that Shirley Couch was an opioid naive patient in June of 2017 when she was admitted to Homestead Hospice care.
Objection leading.
Same, join.
Was Shirley Couch an opioid naive patient when she was admitted to Homestead Hospice in June 2017?
I think she was essentially opioid naive at that point.
So, and that's when you suggested, so the maximum dose for an opioid naive patient, assuming it was clinically indicated, and it was not clinically indicated here, is that right?
That's right.
Objection leading.
But if it was clinically indicated for a patient, then the maximum starting dose would be what?
I think 20 milligrams a day.
Okay. And Dr. Shiver prescribed her how many milligrams a day? Before we get to the benzodiazepines and the antipsychotic, how many milligrams of morphine a day?
She received as much as 600 milligrams of morphine equivalents per day.
Yes, sir. And how much does it take to kill an opioid tolerant patient?
So an article came out in 2010. 2010 marked a huge shift in the way we use opioids, because in 2 articles that appeared in the Annals of Internal Medicine, we learned that—
Let me object to this testimony as to bolstering opinions and misusing publications and medical literature.
You may answer.
So we learned from these 2 articles that patients were dying of opioid overdose at the dosages that we were prescribing. And these were obviously opioid tolerant patients.
By we, you mean physicians generally, not you.
Yeah.
Right.
So there was an increase in spontaneous death at 50 milligrams per day, and an even more important increase in spontaneous death, an 8-fold increase at 100 milligrams per day of morphine equivalents.
All right. So based on your education, training, and experience, and your understanding of the current state of medicine, in 2010, 50 milligrams a day of opioids or opioid equivalent meant what?
It meant an increase in death rates.
Okay. And 100 milligrams per day meant what?
An 8-fold increase in the death rates.
In other words, if somebody got 100 milligrams of morphine in a single day, they were 8 times more likely to die.
That's correct.
Have you ever heard of anyone being prescribed 600 milligrams of morphine in a day?
Objection, misstates evidence.
You may answer.
I know of one case.
All right. Tell me about that case.
Object to this as irrelevant.
You may answer.
This was a patient who was on, I don't remember the exact dosage, and his wife died of an opioid overdose, and she was not prescribed it. So even taking just a fraction of what he was being prescribed killed her. So, you know, it was a bad situation.
So I'm not sure. So who was taking 600 milligrams of opioids a day?
Well, the patient was prescribed it. but it was his wife who died of the overdose. So he was sharing it with her apparently, or she was stealing it. Yeah. And this was around about 2010.
And who prescribed this patient 600 milligrams of opioid a day?
It was,
Objection.
Join.
You may answer.
okay, so it was one of our PAs at the Boise, Idaho VA under the direction of a non-VA neurosurgeon. So he would tell her how much to prescribe, and then she would prescribe it through our pharmacy.
Mm-hmm. And did that patient survive?
Well, apparently he did, but his wife did not.
Okay. Was that physician disciplined?
Objection.
Join.
You may answer.
I don't know about the physician because he was a non-VA physician. The PA had hard cover because she had documentation that he instructed her to prescribe that. She did wind up leaving the VA for her own reasons, though.
All right. If you had a physician that was in your employ that prescribed up to 600 milligrams of morphine in a single day to a patient, would you terminate that physician's employment?
Objection.
Join.
You may answer.
I mean, I would enter them into, depending on the outcome, I would require them to receive additional training and, caution them about more appropriate use of opioids.
All right. Do you agree that the safe range for the administration of opioids to prescribe is 2 to 5 milligrams every 4 to 6 hours?
Objection leading.
Join.
You may answer.
I believe that's in a safe range.
Well, what is the safe range of morphine to prescribe?
Well, like I said, I think, 10 to 20 milligrams for an opioid naive patient, however you define that, would be a safe amount. Again, provided they're not on anything that would add to the risk of overdose.
So would you describe 600 milligrams of morphine per day to be a safe amount?
No.
Would that
Objection.
be safe for anyone either opioid tolerant or not opioid tolerant?
Same objection.
Either one. Even opioid tolerant patients could come to harm at that and would come to harm at that dosage.
What about 500 milligrams? Would you consider that to be a safe dose?
No, I would not.
Would that make any difference whether the patient was opioid tolerant or not opioid tolerant and opioid naive?
I don't think so, because like I said, 100 milligrams a day was killing people who were opioid tolerant. So in this article by Dunn, so,
So same for 400 milligrams a day?
no,
That's unsafe?
I'd say yes, unsafe.
All right. What about 300,
Unsafe,
200,
unsafe.
100?
I would be very concerned at that level.
And those opinions are to a reasonable degree of medical certainty?
Yes,
Beyond that, how certain are you?
absolutely supported by the evidence.
All right. And to a reasonable degree of medical certainty, was it below the standard of care for Dr. Shiver to prescribe the amount of opioids to Shirley Couch that he did in June of 2017?
Objection.
You may answer.
It was below the standard of care.
And is that to a reasonable degree of medical certainty?
Yes,
Beyond that,
Objection.
how certain are you?
very,
Objection.
You may answer.
very certain.
And to a reasonable degree of medical certainty, did Dr. Shiver's prescribing those opioids contribute to Shirley Couch's drug overdose?
Yeah,
Objection.
And that's to a reasonable degree of medical certainty.
yes,
Beyond that, how certain are you?
absolutely certain.
Did Dr. Shiver prescribing those opioids also contribute to Shirley Couch's drug-induced coma?
Yes,
Objection.
Is that to a reasonable degree of medical certainty?
yes,
Same objection.
Beyond that, how certain are you?
absolutely.
All right. And did Renee Bonner's administration of opioids to Shirley Couch in June 2017 contribute to Shirley Couch's drug overdose?
Yes,
And did Renee Bonner's administration of opioids to Shirley Couch in June 2017 contribute to her drug-induced coma?
Objection.
Let me
yes,
answer.
yes,
And are those opinions to a reasonable degree of medical certainty?
yes,
Beyond that, how certain are you?
absolutely certain.
And did the hospice nurses, the defendants in this case, did their administration of the opioids to Shirley Couch in June 2017 contribute to Shirley Couch's drug overdose?
Objection, foundation qualifications.
You may answer.
Yes,
And is that opinion also to a reasonable degree of medical certainty?
yes,
Same objection.
Beyond that, how certain are you?
very certain.
Same.
And to a reasonable degree of medical certainty, did the hospice nurse defendant's administration of opioids to Shirley Couch in June of 2017 contribute to her drug-induced coma?
Yes,
Same
Objection.
Beyond that, is that to a reasonable degree of medical certainty?
yes,
Same.
Beyond that, how certain are you?
Same.
very certain.
I'd like to talk to you about the opioid fentanyl. I believe you've already testified that Dr. Shiver prescribed a 50 microgram fentanyl patch in June 2017 to Shirley Couch. Is that right?
Yes,
And that was administered by Renee Bonner or one of the Homestead hospice nurses.
yes,
Object to the point.
Same.
And the fentanyl prescription was below the standard of care.
yes,
And the fentanyl being administered by Renee Bonner or the nurses was also below the standard of care.
yes,
Objection. No foundation for expert testimony against a layperson.
And foundation qualifications.
And are those opinions to a reasonable degree of medical certainty?
yes,
Same.
Beyond that, how certain are you?
very certain.
What is there a black box warning for fentanyl?
Yes, there is.
What is a black box warning for fentanyl?
So all opioids now have black box warnings. And for fentanyl is I believe the most potent of all the opioids. If I'm not mistaken, it says the starting dose should be 12.5 milligrams and patients should be not opioid naive.
Yes, sir.
If you
And
do okay, I'm sorry, go ahead.
go ahead.
I was going to say, if you do the math, 12.5 milligrams a day is about, I think, the equivalent of 40 milligrams of morphine per day, which is outside of the 5 to 20 that I think would be safe. you know? So I think that it makes sense mathematically that you would have to start at the lowest dose, and it would have to be in a patient who was not opioid naive.
And is that opinion to a reasonable degree of medical certainty?
Yes,
Beyond that, how certain are you?
very.
And did the administration of fentanyl to Shirley Couch in June 2017 contribute to her drug overdose and her drug-induced coma?
Objection.
Join.
Join.
May I answer?
Yes,
No, that too is to a reasonable degree of medical certainty.
yes. Yes, very certain. I forgot to mention that the black box warning for opioids all mention the risk of death.
And what is a black box warning?
It's a warning that the FDA requires the manufacturers to warn, and it's something that physicians have to consult before prescribing a medication so that they are aware of the risks.
And was the prescription of the benzodiazepines by Dr. Shiver to Shirley Couch in June 2017 also below the standard of care?
Objection.
You may answer.
Yes,
Is that to a reasonable degree of medical certainty?
yes,
Beyond that, how certain are you?
very certain, absolutely certain.
And Dr. Shiver's prescription of benzodiazepines in June 2017 contribute to Shirley Couch's drug overdose and drug-induced coma?
Objection.
Join.
Yes,
Is that to a reasonable degree of medical certainty?
yes,
Beyond that, how certain are you?
absolutely certain.
And did the Renee Bonner's administration of those benzodiazepines in June 2017 contribute to Shirley Couch's drug overdose and drug-induced coma?
Objection.
You may answer.
Yes,
Is that to a reasonable degree of medical certainty?
yes,
Beyond that, how certain are you?
absolutely certain.
You mentioned earlier Haldol. Why was first of all, was the prescription and administration of Haldol to Shirley Couch in June 2017 below the standard of care?
Objection.
You may answer.
Yes,
And why was the prescription and administration of Haldol to Shirley Couch in June 2017 a breach of the standard of care?
Objection.
Same objection.
You may answer.
because there was no medical indication for it. Haldol is an antipsychotic, and as such is approved for the treatment of psychosis. I did not see a reference to psychosis in the records that I reviewed.
All right. And for those reasons, it was below the standard of care to prescribe that drug to Shirley Couch in June 2017?
Objection.
You may answer.
Yes,
It was also below the standard of care to administer that drug, Haldol, to Shirley Couch in June 2017?
Objection.
You may answer.
yes,
And are those opinions to a reasonable degree of medical certainty?
yes,
Beyond that, how certain are you?
very certain.
And did the prescription and administration of Haldol to Shirley Couch in June of 2017 also contribute to her drug overdose?
Yes,
Did they also contribute to her drug-induced coma?
Objection.
Join.
And are those opinions too to a reasonable degree of medical certainty?
yes.
All right. I'd like to talk to you now about your review of Shirley Couch's case. What was the date of Shirley Couch's care?
The date of her care?
Yeah, what month and year?
Well, for the period I was interested in, I think it was June 1 through June 26 of 17, I guess.
All right.
Or was it-
And I'm sorry, go ahead.
I think it was 17.
Yeah. Did you perform a detailed review of the medical records for Shirley Couch?
Yes,
And the home hospice where Shirley Couch was cared for?
yes,
And did you form opinions about the care in Shirley Couch's case?
yes.
And who was responsible for the safety of Shirley Couch and when she was in the care of hospice?
Same objection.
Objection.
You may answer.
Ultimately, Dr. Shiver, the nurses who were caring for her, and obviously family, but but professionally the nurses and Dr. Shiver.
So that responsibility was shared?
Yes.
Objection.
Based on your review, were you able to determine what happened from June 1st and June 22nd to on or about June 26th when Shirley Couch was transported by ambulance from hospice care to Athens Regional Medical Center?
Yes.
What happened?
So she was administered progressively more and more sedating medications at increasing dosages.
Yes.
And because of that, she experienced a clinical overdose on sedatives and opioids, resulting in altered mental status, obtundation, or coma, as it was called at the hospital, Augusta, and then I guess that says it. She overdosed.
By obtundation, what does that mean?
Obtundation is it's an unresponsiveness. It can also refer to coma, but those are patients who become obtunded. They cannot respond. They're that sedated. They don't respond to their name. They don't respond to shaking, and
Right.
so she was either obtunded or in a coma.
And in your professional opinion, what caused Shirley Couch's obtundation and coma?
High dose opioids in combination with benzodiazepine and antipsychotic.
All right. And was it a breach of the standard of care for Shirley Couch to receive the amount of drugs that she received in June of 2017?
Objection.
Join.
Yes,
Yes, it was.
and who breached the standard of care in that regard?
Same objection.
Join.
So it would have been ultimately the prescriber, but you know, I know that nurses have a duty to not carry out physician's order if they believe it's potentially harmful to a patient. So I would have to include the nurses in that as well.
And did you come up with some violations of the standard of care applicable to this case?
Yes.
What were those generally?
Objection, this is getting cumulative.
Join.
The first one was that Ms. Couch was not a candidate for hospice care.
And
Patients who are
yep, go ahead.
patients who are admitted to hospice have diseases that have a more or less predictable course. She was not, in my opinion, terminally ill.
All right.
Uh,
And was it
so-
below? Yep, go ahead.
So I believe that was below the standard of care because, you know, it had to be believed that the patient would live no longer than 6 months. And I did not see anything in my review of the case that indicated that she would be dead in 6 months, that would be a predictable outcome based on the diagnoses that she already had. The second issue that I had was that I didn't see an indication for opioids, particularly at those dosages. The only pain I was aware of that she was having was knee pain from osteoarthritis. And the treatment for that is acetaminophen, lidocaine patches, you know, topical treatments. So the use of opioids, I did not see the indication for it, particularly at those dosages. The next one was the benzodiazepines. I did not see an indication for those. You know, typically they are used for detoxification and the short-term treatment of anxiety. It was not clear to me that she did have anxiety. And if she had generalized anxiety, there are better treatments, SSRIs, SNRIs, for that. It's only for the short-term treatment of anxiety and detoxing patients.
All right.
So, and then finally, the antipsychotic haloperidol. Haloperidol is an antipsychotic. It's a potent antipsychotic. I did not see evidence of psychosis. And, you know, the haloperidol, so haloperidol, the potential consequences of prescribing haloperidol are falls, because patients, especially elderly patients, can become easily Parkinsonian. And part of the Parkinsonian syndrome is postural instability. She also had some mild swallowing difficulty going into hospice, and you would anticipate that the swallowing difficulty would get markedly worse because of dyskinesia caused by the haloperidol. So that's a big concern in elderly patients, is swallowing difficulty and aspiration on potent antipsychotics like haloperidol. You know, there are even worse potential outcomes like neuroleptic malignant syndrome, which is potentially fatal, where patients who are given dopamine blockers like haloperidol can develop a fever and rigidity. So my point is, to justify the use of haloperidol, you really do have to have psychosis because of the potential downside. Similarly, with benzodiazepines, the downsides include cognitive effects. They increase the risk of Alzheimer's and increase the risk of confusion and delirium. They're also known to cause falls in the elderly. So again, you want to have a pretty high threshold for prescribing them. And then, like I say, with the opioids, you know, there's the risk of death. You know, also depression, and so severally, all of them pose serious problems, especially if there's no really clear indication. Collectively, it's really a problem because there is a separate black box warning for benzodiazepines administered in patients who are on opioids. And it's impossible to know exactly to what degree this is true, but I generally estimate that if a person is given, I try to avoid benzodiazepines in all patients on opioids. If they have to be used, you got to use the minimum effective dose for the shortest period of time. And, the patient has to be aware that benzodiazepines given in combination with opioids is especially problematic in terms of respiratory depression and death. They do add a lot to that. And generally speaking, medications like haloperidol do not suppress respirations and cause death, but they do contribute to suppression of activity of the central nervous system and add on to what you already have with the opioids and the benzodiazepines. So those are the main things. Not a great candidate for, not a good candidate for hospice, not a good candidate for opioids, not a good candidate for benzodiazepines, not a good candidate for antipsychotics, and then the combination of those is especially problematic.
All right. And could you state to a reasonable degree of medical certainty that those violations led to Shirley Couch's drug overdose, drug-induced coma, and hospital stay?
Objection.
Join.
You may answer.
Yes,
And beyond that, how certain are you?
absolutely, sir.
And those are violations of both Dr. Shiver's standard of care and the nursing standard of care?
Objection.
Objection.
You may answer.
Yes,
And beyond that, how certain are you?
very certain.
And is there any difference in a standard of care or standard or rule?
Objection.
I'm not sure I understand the question. Could you ask me again?
Sure. When we talk about a physician's violation of the standard of care or a nurse's violation of the nursing standard of care, is the standard of care equivalent to a rule?
Objection. That calls for a legal conclusion. It is an incomplete hypothetical.
And it misstates the definition of standard of care in accordance with Georgia law.
You may answer.
It is a kind of a rule. Yes. I mean, it's a, it's a, it's a guidelines,
All right.
rule. I think it's a kind of a rule. It's not a word rule is not a word that we use much.
All right. So guideline.
Yeah, guidelines, standard of care. Those are
Right.
what we use. I mean, those are expressions we use.
Were both Dr. Shiver and hospice nurse defendants responsible for those violations?
Objection.
Join.
Yes.
And to a reasonable degree of medical certainty, Dr. Shiver and the hospice nurse defendants' care fell well below the standard of care in this case?
Yes.
Objection.
I would say absolutely with respect to the prescriber. With the nurses, I would say very certain.
All right. And to a reasonable degree of medical certainty, did their violations of the standard of care cause Shirley Couch's drug-induced coma?
Objection.
Join.
You
Join.
may answer.
Yes,
Beyond that, how certain are you?
absolutely certain.
I'd like to go through your standard of care violations, one at a time, the 5 or so.
Yes.
First, how Dr. Shiver fell below the standard of care by admitting Shirley Couch to hospice care when she was not an appropriate hospice patient. Is that right?
Yes, so
And that's, and you testified there was no terminal diagnosis. Can you give us some examples of terminal diagnoses and explain why Shirley Couch did not have a terminal diagnosis?
I'm going to state an objection based that this witness is not qualified to give such an opinion.
Join.
You may answer.
So she did not have a terminal illness, and like a better example of an appropriate patient for hospice would be someone with cancer. So you have a patient who has cancer, it's incurable. You have a really good idea of approximately the course of the disease. And so for a patient like that, you can have a reasonable expectation that they will not live more than 6 months if they have metastatic cancer and it's no longer amenable to treatment.
Right.
And so with that patient could have lots of pain, as cancer patients often do. And so they require that degree of care of hospice. Another example would be like at a certain stage, ALS, Lou Gehrig disease. So that's something where at a certain point you have a good idea of what the course of the disease is going to be. The diagnosis going into hospice was, I believe, end-stage CVA, which does not conform to the use of those terms in medicine today.
And what is a CVA?
The CVA is a stroke, so end-stage stroke. I think you could possibly apply that to someone who had a large infarction leaving them in a vegetative state. I think you could get away with using the term that way. But the only stroke she had was one that left her weak on the left side. And that was of some years duration, so there was no indication that, so cerebrovascular disease. So if you were going to use a term to describe what she had, you say cerebrovascular disease. She had cerebrovascular disease. That was their rationale for putting her in hospice. But cerebrovascular disease does not have a predictable course. It's episodic. And so, she may have a TIA, she may have another stroke. TIA is a transient ischemic attack. It's like a temporary loss of blood flow to a part of the brain that is reversible and doesn't leave a deficit. So my point is that there is not a predictable course to cerebrovascular disease.
All right. And as a result, Dr. Shiver ought not to have admitted Shirley Couch to hospice care in June 2017?
That is correct.
Objection.
Was it below the standard of care for Dr. Shiver to admit Shirley Couch to hospice care?
Yes.
Objection.
Is that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Very certain.
I'd like to next talk about the next needlessly dangerous violation of the standard of care.
Objection to the characterization of that question.
Objection, that wasn't your question.
You testified that there was no clinical indication to warrant the opioids that Dr. Shiver prescribed and that were administered by hospice nurses or Renee Bonner or both. Is that right?
Yes.
And was that a violation of the standard of care?
Yes.
Objection.
By both Dr. Shiver and the nurses?
Objection.
Same.
And is that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Very certain.
And did those violations also contribute to and cause Shirley Couch's drug overdose drug-induced coma, and her transfer by ambulance to the Athens Regional Medical Center?
Objection.
Join.
You may answer.
Yes.
I'd like to talk to you now about the third needlessly dangerous violation of the standard of care.
Objection, move to strike.
Testified that there was no
Join.
clinical indication for benzodiazepines in Shirley Couch's case in June 2017 when she was under the care of Hospice and Dr. Shiver. Is that right?
That's correct.
And was the prescription and administration of the benzodiazepines in this case a violation of the standard of care?
Objection.
Join.
Well, number one, that he's not qualified, and number two, this is at least the third time he's been asked this.
Join.
You may answer.
Yes.
Is that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Very certain.
And did that prescription and administration of benzodiazepines by Dr. Shiver, the hospice defendant nurses, and Renee Bonner also contribute to and cause Shirley Couch's a drug overdose and drug-induced coma?
Objection.
Object. Again, qualifications, foundation, as well as cumulative.
You may answer.
Yes.
And the next of the needlessly dangerous violations of the standard of care
Objection, move to
was
strike.
no
Join.
clinical indication for an antipsychotic drug. Is that right?
That's correct.
Was it below the standard of care for Dr. Shiver to prescribe and the nurses or Renee Bonner or both to administer an antipsychotic drug in June
Objection.
2017 to Shirley Couch?
Objection.
Join.
You may answer.
Yes.
And is that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Very certain.
And to a reasonable degree of medical certainty, did those violations also contribute to and cause Shirley Couch's drug overdose and drug-induced coma?
Objection.
Join.
Yes.
And necessitate her transport and stay at Athens Regional Medical Center?
Yes.
And I'd like to talk to you now about the next needlessly dangerous violation of the standard of care. I believe you testified that it was
Objection.
extremely dangerous for
Join.
these drugs to be used in combination or combined. Is that right?
Yes.
Objection. The misstates the witness's testimony and is leading.
Was
Same.
it below?
Join.
Was it below the standard of care for Dr. Shiver to prescribe 4 opioids, 2 benzodiazepines, and an antipsychotic to Shirley Couch in June of 2017?
Yes.
And is that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Absolutely certain.
And to a reasonable degree of medical certainty, did that contribute to and cause Shirley Couch's drug overdose, drug-induced coma, and transport to Athens Regional Medical Center?
Yes.
Objection.
Join.
Yes.
Was it also below the nursing standard of care for the nurses not to advocate on behalf of their patient, Shirley Couch, when she was receiving these drugs in June of 2017?
Objection, foundation, as well as leading this witness.
You may answer.
Yes.
Is that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Very certain.
And did that breach of the standard of care also contribute to Shirley Couch's drug overdose, drug-induced coma, and transport to Athens Regional Medical Center?
Yes.
Same
Objection.
objection.
Yes.
Was it also below the standard of care for Dr. Shiver and the hospice nurse defendants not to recognize or treat Shirley Couch's drug overdose and drug-induced coma?
Objection?
Same objection and leading.
You may answer.
Yes.
Is that opinion also to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Absolutely, sir.
Did that also contribute to and cause Shirley Couch's drug-induced coma and the necessity of transporting her to Athens Regional Medical Center?
Objection.
Join.
You may answer.
Yes.
And is that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Absolutely, sir.
The time is 8:13 p.m. We are back on video record.
Dr. Albanese, I show you what has been marked as Plaintiff Exhibit 2 to your deposition. This is a copy of your CV. Can you see that all right?
Yes, it's pretty small, but I can make it out, yeah.
All right. Does that accurately reflect your education, training, and experience?
Yes, it
I'll
does.
just put an objection on the record as it relates to any attempts to have the CV go back with the jury.
Join.
Show you what's been previously marked as Exhibit 3 to your deposition. This is, have you seen this photograph before?
Yes,
And what is that?
that's a picture of Ms. Couch.
Yes, sir. And are you aware that that was taken on June 22nd, 2017?
Yes,
I'll show you what's been previously marked as Exhibit 4 to your deposition. And have you seen that photograph before?
yes,
And did you see that photograph in conjunction with depositions that you read and it was attached as an exhibit to those?
yes,
And is it your understanding that this photograph was taken 4 days later on June 26th?
yes.
And does Shirley Couch appear to be getting better over the course of those 4 days?
No,
Would you be able to explain the changes that you see in those two photographs from the amount of drugs that she was prescribed and administered by the defendants in this case?
Objection. Calls for
May I answer?
speculation and lack of foundation.
Join.
yes, so in the first picture, she appears alert.
You want me to
In
pull
this
that back
picture-
up? Hold on.
In
You
the
see
second
that?
picture,
Yep.
she appears to have altered mental status.
All right.
It looks like she has depressed consciousness in the second picture.
I'll show you what has been previously marked as Exhibit 5. For the record, these exhibits are being shared in chat, both to you, Madam Court Reporter, and to opposing counsel. Have you also seen this photograph before?
Yes, actually, yes, I have.
And what is that?
Well, it's meant to represent how small an amount of fentanyl would be necessary to cause death.
And does that accurately represent, in your view, the amount of fentanyl it could take to cause death relative to a Lincoln Head penny?
Yes.
And do you know whether that's a DEA photograph?
I do not.
But that photograph accurately depicts the lethal amount of fentanyl relative to a Lincoln Head penny.
Yes.
And I'm going to object to the use of these demonstratives with the notes at the top.
Sorry, I couldn't what did you say, Tom?
I'm going to object to the use of these demonstratives with the notes at the top that are above the actual picture.
I'm going to show you, this is number, is it 6, Madam Court Reporter?
That's correct.
Thank you. Exhibit 6. Does this accurately depict the lethal doses of fentanyl and carfentanil relative to a lethal dose of heroin?
It makes sense to me. Yes, it's much more potent than heroin.
All right. Fentanyl.
Yes, fentanyl is, and fentanyl accounts for a high burden of the opioid overdoses that we're seeing today.
I'm going to show you what's been previously marked as Exhibit 7. And is this a document you also reviewed?
Yes.
Your review of the depositions?
Yes.
And this is a form of medication administration record. Is that your understanding?
That is correct. Yes.
Join.
Objection.
And does that indicate to you the milligrams of morphine that were given on June 25th, 2017?
I don't suppose you could zoom in a little there. I mean, that, yes.
I'll show you what has been previously marked as Exhibit 8. Have you seen this document before?
Yes.
Objection, Foundation.
And what is that?
It's a summary of the administration of the medications we've been talking about.
Yes, sir. And does that does that accurately reflect the medication that was administered pursuant to that handwritten medication administration record that we marked as Exhibit 7?
Yes, I found it to be concordant.
And the morphine that it was administered on 25 June, before you include morphine equivalents attributable to the fentanyl, was in excess of 330 milligrams of morphine. Is that right?
That's how I recall it. Yes, it's kind of small there, but yeah.
And if you add to that the 120 milligrams morphine equivalent from fentanyl, that's a total of how much morphine or morphine equivalents administered to Shirley Couch on June 25th,
I
2017?
believe that's 450 milligrams of morphine equivalents. So it was 330 plus 120.
All right. And you agree that that's a dangerous amount of morphine?
Yes.
And is it more or less dangerous when you add in the Ativan and the Valium that was also administered to Shirley
It's
Couch?
significantly more dangerous.
And is that to a reasonable degree of medical certainty?
Yes.
And was it below the standard of care for Dr. Shiver to prescribe those benzodiazepines along with that morphine and fentanyl?
Yes.
And that too is to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Absolutely certain.
And was it also below the standard of care for the nurses, not to advocate on behalf of Shirley Couch to ensure that that 450 milligrams of morphine was not administered to Shirley Couch in that 24-hour period?
Objection, lack of qualification, foundation.
You may answer.
Yes.
And is that to a reasonable degree of medical and nursing certainty?
Yes.
Attached to that was created by James Shiver on 6/12/2017 at 7:28, a narrative source, Shiver, medical director. If you read that, will you point out for us any terminal condition present there?
I do not see one.
What about this severe, well, is 81-year-old female, is that a terminal condition?
You could make that case, but not within 6 months necessarily.
Yes, sir. And what about severe cerebral hemorrhage that occurred, I believe in this case, in 2008? Is that right?
Yeah, I mean, no, that's not a terminal condition.
All right. And what about the flaccid hemiplegia?
That's not a terminal condition.
That severe cerebral hemorrhage, is that a stroke?
Yes.
And are there people that have had a stroke in years past that are still living, functioning members of society?
Yes, yes, of course.
And the flaccid hemiplegia, what does that refer to?
I think that's actually inaccurate, but that means that the left side of her body is flaccid. In other words, it's has low muscle tone, and is not usable.
Yes.
And I don't think that's accurate.
And why don't you think that's accurate?
Because so I asked her to describe her current status, and she describes more of a spastic hemiparesis. So hemiplegia means the left side is not usable at all. A hemiparesis means that the left side is affected but still usable, and it's more spastic than flaccid.
All right.
Move to strike with regard to hearsay.
Join.
And what about continued problems with TIAs? What are TIAs?
Those are transient ischemic attacks, and those are temporary loss of some neurologic function that is restored when the blood flow is restored. So there's a temporary loss, a temporary compromise of blood flow to a part of the brain, but it restores itself, and so it's just a transient ischemic attack. They don't leave a deficit.
All right. Is that a terminal condition?
No, it isn't.
All right. Hypertension. What does hypertension mean?
High blood pressure.
Well, if I have high blood pressure, does that mean I'm going to be dead in 6 months?
No,
Is hypertension a terminal condition?
no.
What about carotid artery disease? What is a carotid artery?
The carotid artery is the major artery going from the thorax or chest to the brain. There's one on each side, and carotid artery disease means that there is narrowing of the carotid artery.
Is that a terminal condition?
No,
And it goes on to read previous. Do you see previous clotting disorder? What does it mean when a physician writes previous clotting disorder?
Objection.
but there was a clotting disorder in the past.
Is a clotting disorder in the past a terminal condition?
No,
Pneumonia. Is pneumonia a terminal condition?
no.
What is pneumonia?
Pneumonia is a disease of airspace of the lungs. It's an infection, typically caused by a bacteria or virus.
All right. And it also reads continuing decline. Based on your conversation with Shirley Couch, was she in continuing decline?
No,
Objection.
Anything in the record suggests that she was in continuing decline?
no,
Reads here, her life expectancy is less than 6 months. Would you agree with that?
no.
Why not?
Because there's none of these conditions has an established trajectory, an established clinical course. Cerebrovascular disease, which is, I believe, what they're all talking about, what Dr. Shiver is talking about, but he doesn't state specifically, does not have a predictable course, and neither does hypertension or a clotting disorder. Certainly, pneumonia is something that can be treated. So, no, I don't see anything that looks like a terminal illness.
All right. And as a result, was it below the standard of care for Dr. Shiver to admit Shirley Couch to hospice care in June of 2017?
Yes,
Objection.
And is that to a reasonable degree of medical certainty?
yes,
Objection.
Beyond that, how certain are you?
very certain.
And to a reasonable degree of medical certainty, did that contribute to and cause Shirley Couch's drug overdose, drug-induced coma, and her necessary trip to Athens Regional Medical Center?
Objection.
Join.
You may answer.
So, could you restate the question?
Sure. Did Dr. Shiver's breaches of the standard of care in that regard contribute to Shirley Couch's drug overdose, drug-induced coma, necessitating a trip to Athens Regional Medical Center?
Yeah,
Join.
Join.
yes, in that aggressive use of sedatives and opioids are appropriate for many of the patients who go into hospice. For example, people with metastatic cancer. She was not such a patient, but she was managed as if she were. And that led to her opioid overdose. Her mental status changes due to the administration of high-dose opioids, benzodiazepines, and an antipsychotic.
All right. That's all the questions I have, Dr. Albanese.
You go.
Hmm?
You want to go? You want me to go?
I can go. Hi, Dr. Albanese. My name is Sharonda Barnes. I represent Dr. James Michael Shiver, okay?
Hi, Sharonda.
Hi. Do you need a break or anything before we get started, or are you okay?
I'm okay.
All right. You're not board certified in geriatric medicine, correct?
That's correct.
And you've never made any attempts to become board certified in geriatric medicine, correct?
That's correct.
You're not board certified in hospice or palliative care, correct?
That's correct.
And you've never made any attempts to become board certified in hospice or palliative care, correct?
To be frank, I was considering it back in 2011, but it was already too late to do it. By the next year, maybe it was 2012, it was too late to do it using the practice pathway. So I would have had to do a fellowship. So yeah, I was considering it, but didn't do it.
You've never either sat for an examination or did the training practice fellowship in order to become, in an attempt to become board certified in hospice or palliative medicine. Is that correct?
That's correct.
When we were talking about your background earlier, you mentioned that you served as the chief of medicine from 2008 to 2013 at an institution, and I apologize, I missed that name.
It was the Boise, Idaho VA. So it was the
Okay.
VA Medical Center, and it was most of that period of time. I don't remember the exact dates, but it was most of that period of time I was chief of medicine.
Do you recall what periods of time during 2008 and 2013 you served as the chief of medicine?
I can't remember. It's on my CV though.
I think your CV says that, oh, go ahead.
There was a year or so, I think, that I was in an acting position, and then I think 2 years where I was in that position official.
Okay. On your CV, you mentioned from 2012 to 2013 at the Boise VA, you were serving solely as a psychiatrist and psychosomaticist as a consultant or liaison. Do you believe you were still serving as chief of medicine during 2012 to 2013?
No, I was not.
Okay. So is it accurate to say that the last time you served as the chief of medicine for Boise VA was in 2012?
Yes,
Is it fair to say that since 2012, you have not overseen any medical director for hospice positions?
that is correct.
Is it accurate to say that since 2012, you have not served as the primary caregiver for any hospice care patients?
That is correct.
Is it fair to say that since 2012, you have not been responsible for making any hiring decisions for the medical director of a hospice position?
That's correct.
And you stated now that your practice is predominantly psychiatry, correct?
That's correct.
And how long has that been the case?
I would say 3 years.
So since 2018?
Yes.
When is the last time that you evaluated a patient to determine whether or not they met the qualifications for hospice?
That would have been 2012 or before.
So since 2012, you have not performed any evaluations to determine whether or not a patient is medically appropriate for hospice. Is that correct?
That's correct.
Is it also fair to say that since 2012, you have not ever signed the terminal illness certification for a patient that is entering hospice?
I believe that's correct.
And finally, is it accurate to say that since 2012, you have not been primarily responsible for writing hospice medication admission orders for patients?
Yes, that's correct.
You testified earlier that you taught medical students on the use of narcotics and benzodiazepines. When is the last time you've taught a medical student regarding those subject areas?
I believe it was 2 years ago. I had an osteopathic student at St. Helena Hospital here in the Napa Valley.
And so you taught one student?
Yes.
And what type of student was that?
It's an osteopathic student. You know, it's like a medical student. It's essentially the same as a medical student. They're DOs instead of MDs, but they can do all the same residencies that we do, and slight difference in training.
Is it fair to say that since 2012, you have not routinely taught medical students regarding the use of narcotics and benzodiazepines?
Oh, that is not correct, because until 3 years ago, you know, I was at the Menninger Clinic in Houston, and I had medical students, I had residents, I had, you know, I taught colleagues, you know, so yeah, up until 2018, I would say it hasn't been, but before that, up until 2018, September 8th, 2018, I was doing a lot of teaching at Baylor and Menninger Clinic.
When is the last time you prescribed an opioid pain medication for a hospice patient to treat pain?
Gosh, I can't remember. It would probably have been before 2012.
And was it prior to 2012? We'll strike that. Let me ask you this way. When is the last time you prescribed benzodiazepines for a hospice patient?
I don't think I've ever done that.
And when is the last time you prescribed any antipsychotic medication for a hospice patient?
I don't think I've ever done that.
And you've never done that because you've never been primarily responsible for writing prescription medication orders for hospice patients throughout your medical career, correct?
No, it's because I know I had to do it when I was at the Boise VA because I had to cover that unit sometimes. It's just that it was, in my opinion, it was never clinically appropriate to use a benzodiazepine or
Jack, hold on.
those patients.
Go ahead, doctor. You can finish answering the question.
Yeah, it was because I never thought, I didn't encounter a case where I thought it was clinically appropriate to use those medications in the hospice patients that I was covering for.
And the only time that you would have been responsible for writing prescription medication orders for hospice patients during your time at the Boise VA is if you were providing coverage for another physician, correct?
Yeah, if I was on call, yes, that's right.
But that would have been the primary responsibility of the medical director of hospice, correct?
Yes, unless they, yeah, of course, if they weren't present, you know, it's my responsibility. But
okay, I want to ask you a couple of questions about your first opinion that you believe that Ms. Couch was an inappropriate patient for hospice. You reviewed with Mr. Potts the materials that you reviewed in order to formulate your opinions in this case, and you did not mention the deposition of Dr. Park. Did you review the deposition of Dr. Park, Ms. Couch's primary care physician?
I did, yes.
Okay, and what is your understanding as to why Dr. Park made the initial order for Ms. Couch to be placed in hospice?
Well, he believed that, he stated that he believed that she was appropriate in the sense that she had 6 months or less to live. I did not agree with that assessment. So, you know, so I didn't think that was accurate.
You would agree with that this recommendation was made in May of 2017, correct?
May, yes, I believe that's right. It was May of 2017.
And you would agree that this determination that Ms. Couch was hospice appropriate was made without any involvement in May of 2017 by any Homestead Hospice employees, correct?
I'm not sure that's true.
Who from Homestead Hospice was involved in Dr. Park's assessment in May of 2017?
Well, all I said is I'm not sure that's true. I know that Renee Bonner worked for Hospice and that she had had a private conversation with Dr. Park after he'd examined Ms. Couch.
Okay, I'm going to turn and I will share my screen with you. These are Dr. Park's notes. Can you see that?
Yes.
Okay. And you'll agree with me that Dr. Park reported that Ms. Couch has had a significant decline in her health in the last 30 days, correct?
Object to the form of the question. I'm going to object to you asking any questions about any documents without, one, showing him the document in its entirety, two, identifying the document for the record, and three, sharing the document with opposing counsel, that's me, via chat in the court reporter. He's not going to answer your questions unless you do that. I'm entitled to see the document. I need to see it.
These are documents that were produced by you, James, so you have these documents. I'm showing, no, James, let me finish my statement. Thank you very much. No, I'm not going to send you the document. You have the document. And if you need to see anything, Dr. Albanese, on that is not on here, I'm happy to scroll and refer you to anything that you need to see. And I'm happy to upload these at the end so that we can make sure that everybody has these documents. But these are documents that have been used in discovery, were used and attached as exhibits to Dr. Park's deposition. Everybody involved in this case has access to these documents. So Dr. Albanese, I'm showing you, which I've already stated for the record, but I'm showing you again.
Object to the form of the question to the extent that you're asking a witness about a document without showing the witness the document in its entirety. When I want to see the document without sharing the document with me, and I'm going to object to him answering any questions without you sharing the document.
Jim, you see the document on the screen, correct?
You see the document on the
I see
screen.
a portion of the document. You're referring to Dr. Park's medical record, which is several hundred pages, and you're asking Dr. Albanese about a portion of the record. You need to share the exhibit. If you refuse
James,
to do
you
it,
have the
I'll
exhibit.
just continue to object.
Okay, we will go off record and I will email it. This is completely unnecessary, but we will go off record and I will email the documents.
All right.
Isn't it in his file? I thought he testified earlier.
The time is
that it was in
8:49
his
p.m.
file.
We're off video record.
I can't understand you. What did you say?
Isn't this, I thought he testified earlier. Now, let's not go off record. I don't need the video, but stay on record. I thought earlier he testified that he reviewed Dr. Park's records, so he has them, and you've produced them. We've all shared them, and we've got him on cross as if we were at trial.
That doesn't change anything, and it certainly doesn't change the rule. If you're going to show the witness a document, show me the document. I'm entitled to see it. He's entitled to see it. I want to see it.
James, I've shown him the document before the record on cross. You cannot instruct your witness not to answer a question because you don't have the document in front of you. That's not the law.
And you did the same thing. You showed him pieces of records and documents during direct. And so now you're saying you had an obligation to share all of it with the witness and to us?
I'll share the documents with you. Share the documents, or don't ask him questions about it, or I'll object to it.
Well, we're going to have to.
You're not going to be able to do it.
We're going to have to terminate the deposition.
Mr. Mazziotti. Stop it.
We're going to have to terminate the deposition.
No, we're not going to do that. I'm not going to do that.
Well, we're going to terminate the deposition if you're going to continue to be
a document, or don't ask questions about it.
All right, James, you have the document. I'm moving on. Dr. Albanese, I'm asking you about the Oconee primary care medical record that I understand you have reviewed as part of your review in this case, correct?
Object to the, hold on, Dr. Albanese. Don't answer the question until I get my objection in. I object to the form of the question. You've not shared the document in its entirety with opposing counsel. That's me or the witness.
James, if you could kindly check your email, it has been shared with you for the second time now. So, Ms. Mansani, would you mind reading back my question?
Did you email me the document?
I did.
All right, hold on.
Dr. Albanese, do you have this document in front of you?
Object. I don't have the document. Did you
I'm
send
not,
it?
I'm asking Dr. Albanese a question. Do you have the
I'm saying
document
I'm
in front of you?
objecting. Don't ask the question until I have the document.
Okay, I can ask the question without you having the document in front of you. Dr. Albanese, do you have this document in front of you?
I object.
Okay, your objection's on the record. Do you have this document in front of you?
All I have is what you're showing me on the screen.
What I'm asking is to come and prepare your testimony today. Did you bring copies of any of the medical records you reviewed in this case?
No, I just, I know where I can get them, but I don't have them in front of me, no.
Is it correct, sir, that you don't have any of the medical records in front of you to provide your testimony today?
Objection
No.
asked and answered. He's already answered that question. Do you have another question?
I'm asking for any medical records. This is a different question, James. Your objection is noted. Dr. Albanese, did you bring any medical records with you in order to provide your testimony today?
No.
Okay, you didn't feel like that was important?
Object to the form of the question.
My understanding is, I review the documents and I prepare my answers based on my review. I'm surprised to learn that I would have to produce the documents.
Have you committed all of Ms. Couch's medical records to memory in order to provide the most accurate testimony for yourself today?
Object to the form of the question. It's also argumentative. You don't have to answer that question, Dr. Albanese.
Are you instructing him not to answer that question?
I am not.
On what grounds, James? For the record, what
If
grounds?
you're going to ask him a question, I'm going to object. And I'm objecting again.
Dr. Albanese, you can answer the question.
No, I did not commit them all to memory.
Okay. I am showing you a portion of Ms. Couch's medical records from Oconee Primary Care, which you understand to be Dr. Park's medical office, correct?
Yes.
Well, what page are you
And we'll mark
showing?
this as defendant's exhibit number one.
Object. What page of the record are you showing it?
I haven't gotten to that, James. I've marked this as defendant's exhibit number one. Dr. Albanese, I'd like to turn your attention to the medical record entry from May 30th of 2017, which I understand you reviewed as part of your review in this case, correct?
Yes, this looks familiar,
Okay.
yes.
All right. And under this record, it states that Ms. Couch has had a significant decline in her health in the last 30 days, correct?
Yes,
It says she has had recurrent UTIs due to urinary incontinence and inability to stand. Did I read that correctly?
yes,
And also note she is at high risk for having more CVAs, but she cannot tolerate anticoagulation due to recurrent falls and history of severe hematoma. Did I read that correctly?
yes,
And it says that she is hospice appropriate, correct?
yes,
And it ends with saying we'll consult hospice, correct?
yes,
And this was electronically signed by Dr. Ken Park, correct?
yep, yes,
You reviewed the Homestead Hospice records as part of your review in this case as well, correct?
yes.
And based upon your review of those records, did you note where Ms. Couch's family had also reported that she was experiencing a significant decline in her functional and cognitive abilities in the past 3 months?
Yes, I recall something to that effect, yes.
All right, I want to turn your attention to your criticisms regarding the opioid pain medication orders. First, I'm going to show you in the Homestead Hospice records, which you were previously shown, the initial orders for morphine. And I'll mark this as defendant's exhibit number 3. And based upon your review of this order set, you were asked earlier, but what was the order for morphine?
Yes.
What was the order?
It says morphine, 20 milligrams per ml, solution, take 5 milligrams to 20 milligrams every 2 hours as needed for pain / shortness of breath.
You would agree that morphine was only to be administered as needed, correct?
Object, form of the question.
Yes.
Mischaracterizes the evidence.
Yeah, it specifically says as needed.
That is what the prescription states, correct? As needed?
That is what's, yes, that's correct.
And it was supposed to be given as needed for pain and shortness of breath, correct?
Same objection.
Yes, correct.
Norco was then prescribed on June 15th of 2017. Do you recall that based upon your review of the records?
Yes.
And this was in response to a comprehensive pain assessment that was conducted on Ms. Couch on June 15th, 2017, correct?
Yes.
And during that comprehensive pain assessment that was conducted, Ms. Couch reported that she was experiencing increased pain, correct?
Yes, I believe that's correct.
And she also
memory.
I have pulled up the comprehensive pain assessment from June 15th of 2017. Can you see that, Dr. Albanese?
Yes.
And this is
Okay.
what? I needed to see a copy of the record.
You have the Homestead Hospice records. You've been using them during the deposition.
I want to see the exhibit you're going to question the witness about.
Do you have a copy of that? We're going to go off record, and James, I will email you a copy of records that are already in your possession that you have produced in discovery.
All right.
The time is 9:01 p.m. We're off video record. The time is 9:17 p.m. We are back on video record.
All right, for the record, I'll go ahead and mark as defendant's exhibit number 3, the entire Homestead Hospice record. Dr. Albanese, when we took a break.
3 was the order for the.
Yeah, the order's in there, so I'll go ahead and mark that as collective exhibit 3. And Dr. Albanese, when we left, we were talking about the comprehensive assessment that was performed on June 15th. Do you recall that?
Yes.
Okay. And according to the documentation, and I will share my screen so you can see it. Under the section pain management, it noted that the patient is, whether or not the patient is comfortable with the current treatment, and the response was no, correct?
Yes.
What page is this?
It's at the top. It's on page.
I can't see it.
It's on page 2 of the 6/15/2017 comprehensive pain assessment. also a complete assessment of Ms. Couch's pain, where she described the pain as constant, correct?
Objection to the question.
The pain quality and character was described as aching, burning, and shooting, correct?
Yes.
The physical functioning of the pain was severe, correct?
Yes.
And the overall patient pain severity was moderate, correct?
Yes.
And in response to this, this is when the prescription for Norco was made, correct?
I don't remember exactly that, but, it sounds reasonable.
As you reviewed the medical records and prepared to offer opinions related to Dr. Shiver's use of opioid pain medication, did you make any note as to when and why different pain medications were brought on board?
Yes, I did, but I don't remember them all.
Okay. You were asked earlier about the use of fentanyl, correct? And when that was ordered on June 22nd of 2017, correct?
Yes.
And what was your understanding as to why fentanyl was brought on board?
The patient was in pain.
That was in response to another comprehensive pain assessment, correct?
I believe so.
And at this point in time, on June 22nd, 2017, according to this comprehensive pain assessment that I'm showing you, it states, patient is comfortable with current treatment, ? Response, no, correct?
Yes.
The current pain level was noted to be severe, correct?
Yes.
With medications on board at this point in time, which included morphine and Norco, the best relief that Ms. Couch was receiving from her pain was a 5 moderate, correct?
Yes.
And with activity, it was a 9 severe, correct?
That's what's documented.
And you had testified earlier on direct that she was only experiencing pain to her left knee, but per this documentation, she was experiencing pain to her left side, correct?
Left leg, yes.
Is it your testimony that it was only to her leg?
That was my understanding.
And what is that based on?
The degenerative joint disease of the leg, hematoma. That was my understanding of what was going on with her at the time.
You would agree with me that this documentation does not limit pain to her left leg or knee, correct?
It just says predominantly left side.
So the answer to my question is correct, right?
I suppose so, yes.
The quality and characterization of the pain is aching, cramping, sharp, shooting, soreness, stabbing, and tender. Did I read that correctly?
Yes.
And the frequency is constant. Is that correct?
Yes.
And did you read in Dr. Shiver's deposition testimony that that is why he unloaded fentanyl for Ms. Couch?
Yes.
I want to talk to you about the use of benzodiazepines in this case. I understand that you are critical of Dr. Shiver for ordering benzodiazepines in this case, correct?
Yes.
And the first benzodiazepine that was ordered was Ativan. Do you recall that?
Yes.
And I will prescription here on June 2nd of 2017. What frequency does this order set forth?
It says 1 tablet, 0.5 milligrams every 4 hours as needed for anxiety.
And based upon your review, well, first, let me ask you, you would agree that this is to be taken PRN, correct?
Yes.
As needed, correct?
Yes.
And you would agree that Ms. Couch's family had reported that she had been experiencing hallucinations, correct?
I remember some mention of visual hallucinations, yes.
And do you also recall that Ms. Couch was continuously being evaluated for anxiety and depression?
Yes. Actually, no. No, I don't remember that. Why don't you show me that? I know you wouldn't ask if you didn't have it, but.
One moment. All right, I will show you page 12 of the Homestead Hospice records. All right, the last thing I wanted to ask you about was the order for haloperidol, which I understand that you were also critical of. What was your understanding as to why haloperidol was being brought on board?
The only thing I could see was visual hallucinations, and that's not an appropriate use.
You would agree that haloperidol was also brought on for nausea and vomiting and agitation?
But those aren't appropriate uses either.
Is your testimony that haloperidol should not be used for nausea, vomiting, or agitation?
That's correct. Let me amend that. If the agitation is caused by psychosis, it's reasonable to do, but you're treating psychosis, not agitation.
How much haloperidol was Ms. Couch prescribed?
I think she was getting like, 2 milligrams a day. I don't remember exactly.
I will tell you that it's not correct, and I will show you the order. You were testifying earlier that that if you read Dr. Shiver's medication orders as it relates to opioid pain medication, that she was prescribed the equivalent of 600 milligrams a day of morphine equivalent by June 23rd of 2017. Do you recall that testimony?
Yeah, so I think that she got as much as 330 milligrams of morphine and then the fentanyl patch.
You would agree with me that there's no evidence in this case that she actually received 600 milligrams of morphine equivalents at any point in time, correct?
I think that's, hang on a second. As I recall, I believe that she got like 450 milligrams on one occasion. Morphine, 600, no. But that was, I guess that was possible given the order.
Right, but that was not the case in this case, correct?
I believe that's correct.
You're getting paid for your testimony here today, correct?
I've asked not to be
One
paid
other
for this.
question.
Go ahead, I'm sorry, I couldn't understand you.
I asked not to be paid for this.
And why did you ask not to be paid?
Because this started at 3 o'clock and I'm technically on the clock for the state of California until 4:30. And so then if I was paid, I would have to request annual leave. And I just didn't want to do that. I didn't want to be accused of double dipping, so I asked not to be paid for today.
Have you been paid for your review of medical records and deposition testimony in this case?
Yes, I have.
And do you have an estimate as how much you've been paid to date?
I think 6,500.
Do you have any outstanding invoices?
No,
And the money that you have received in this case, that goes to you personally, correct?
yes.
All right, I am going to hand you off to one of the other attorneys. Those are all the questions I have right now. Thank you so much.
Thank you.
Good evening. Before we get started, I just need to get a legal objection on the record, and that is that we are proceeding with Dr. Albanese's deposition this evening without the benefit of a discovery deposition, which was noticed during the discovery period and agreed to. We do not waive our right to redepose Dr. Albanese at a separate time by proceeding this evening.
I join in that.
Join.
And for the record, that objection is untimely. That has to be made at the time of the taking of the deposition, not after the commencement of the deposition.
Good evening. I'm Tom Mazziotti. I represent the Hospice and its nurses. Isn't it fair to say that a doctor must make the referral to a hospice?
Yes,
And the doctor does that based on a medical evaluation,
yes,
taking into account a patient's medical history,
yes,
the patient's current medical status,
yes,
and the physician makes the determination on the anticipated life expectancy, true?
true,
Based on the information at that time,
yes,
not in hindsight.
that's correct.
The nurse does not make an initial referral to hospice, correct?
Correct.
It's the doctor, after the referral that's been made, must accept the patient into hospice.
I'm sorry, could you ask me that again?
Once one physician makes a referral to hospice, another physician must accept that referral for the patient to get into hospice.
Yes.
Comment the question.
The nurse does not accept a patient to hospice, true?
True.
It's the doctor who decides which medications to order for a patient,
Yes,
the dosages,
yes,
the timing of administration.
yes,
It's not the nurse who can order medication
that's correct.
or the dosages.
That's correct.
Okay, I want to talk a little bit about your background. As I understand, currently you're a psychiatrist in California, correct?
That's correct.
And according to your curriculum vitae or CV, you have chosen to emphasize psychiatry as your professional focus, correct?
In the last 3 years, yes.
Okay, so that's a true statement. Your focus right now is psychiatry.
That's correct.
And you're a psychiatrist, is it at St. Helena Hospital?
I'm at the Veterans Home in Yountville now.
And this is an inpatient psychiatric center?
It's a little hard to describe. So I don't want to tell you more than you really need to know, but we are a facility that houses veterans. Some of the veterans live independently, and some of them are at the nursing home level of care. So and then we have sort of acute care beds. So we have a spectrum of outpatient to inpatient, but we don't have inpatient psychiatry. We just have inpatient medicine.
So currently you're not a hospice medical director, right?
That's correct.
And you've never been a hospice medical director.
I think that's accurate, yes.
And you have not supervised a registered nurse in a hospice setting at all, have you?
I mean, so no, but when I was covering the hospice patients in our long-term care unit in Boise, I guess you'd have to say that I was overseeing their work at that time.
But on a day-to-day basis, you have never supervised hospice nurses, correct?
That's correct.
And what you just referred to, where you would periodically cover for another physician, that was in 2012 and before, true?
Yes.
In your fields of interest listed on your CV, it does not list hospice care, correct?
That's correct.
And part of your lectures that I've reviewed, I don't see anything listed for giving a lecture on hospice care, correct?
Well, there's one called Psychiatric Issues and End of Life Care. It's a lecture that I did.
How long ago was that?
That would have been around 2012.
But nothing since 2012, true?
I think I gave an updated version of that lecture when I was in Florida, so that would have been about 2015. I'm not splitting hairs here. I'm just trying to be as accurate as possible.
Okay. So those are the only times you've ever lectured on hospice care, true?
True.
And you don't have any publications related to hospice care, correct?
Let's see. I don't think so, no. Our book chapter may have covered some hospice. Our book, Primary Care Medicine for Specialists and Non-Specialists, I believe we had some reference to hospice in there. I don't know that it was a whole chapter, though.
It's true that you have never authored a publication related to hospice care, correct?
That's probably correct.
And you've never hired, well, since 2012, you have not hired a medical director for hospice care, right?
That's correct.
Since 2012, you've not evaluated a physician for hospice care, correct?
That's correct.
You've not credentialed a physician for hospice care since 2012, right?
Let me think. That's correct.
And when you were back in 2012 and before, this was not home hospice care. This was in a facility, true?
That's true. It was part of a VA long-term care unit.
So that is true that you have never done home hospice care, correct?
That's correct.
And you've never supervised home hospice nurses, correct?
Correct.
Never worked as a hospice nurse?
No, I never have.
Either as a registered nurse or a licensed practical nurse, right?
That's correct.
And in June of 2017, when Ms. Couch was in hospice, you were not working in hospice care at that time, right?
That's correct.
The standard of care does not require a medical director to be board certified in palliative care, true?
I'm sorry, would you repeat the question?
Sure, the standard of care does not require a medical director to be board certified in palliative care, correct?
That's true. That's correct.
In fact, the standard of care does not require any board certification for a medical director in home hospice, right?
I don't know that that's correct, actually.
You don't know that's incorrect either, do you?
I know that anywhere I've ever worked, we would not have hired anyone who wasn't board certified in anything.
That's a different question, though. The standard of care does not require a medical director to be board certified at all, correct?
Object to the form of the question.
I don't think that's correct.
Do you know Dr. Ronald Schwartz, who's been identified by plaintiff as another expert in this case?
No, I don't.
So when he agrees that the standard of care does not require a medical director to be board certified, you would disagree with that statement?
I suppose so.
Okay.
You need to be board certified in something.
But not in palliative care, right?
That's right.
You are not a pharmacologist.
I am not.
You're not a neurologist.
I am not.
You've never been an executive director of a home hospice, true?
True.
You've never had any type of office administration type of job for a home hospice, correct?
That's correct.
Never given any formal teaching for hospice nurses.
I think that's true, yes. Correct.
You've never formally taught registered nurses on administering opioids in the hospice setting, correct?
That's correct.
Never formally taught nurses on administering benzodiazepines in the hospice setting, correct?
That's correct.
And you've never formally taught nurses on administering antipsychotics in a hospice setting.
I believe that's correct, yes.
Earlier, you testified about the teaching positions you held at different areas. You've never formally taught nurses, registered nurses or licensed practical nurses, correct?
I have done several lectures to nurses. I would say 5 or less in an academic setting. Like when I was at Medical University of South Carolina, the nurses asked me to give talks for them. So that's not a lot, obviously, but I want to be as truthful as possible here.
So you've not taught nurses a lot, correct?
That's correct.
And you've never taught a nurse in a formal setting where there was some type of curriculum or agenda, true?
The several that I did when I was in South Carolina, it was part of their curriculum.
But you were not the teacher giving lectures to a nurse over a semester or a year. Is that right?
That's correct.
You were not on their staff as a teacher lecturing registered nurses or licensed practical nurses, true?
I don't know. I think that's probably true, but I don't know.
You would agree that in home hospice medical records, they do not have a medical administration record generally.
I'm sorry, I'm so tired. I'm zoning out here. So would you please ask the question again?
Sure, and I understand.
Need a break, Dr. Albanese?
No, I'm good.
Right.
I just
Yeah.
need. Okay.
Continue to tell me if you're having a
Need a
problem with the
break,
question.
just let me know.
Yeah, it's 9:45 here, so I can appreciate why you're a bit tired. So the question was about documentation in the home hospice setting. Let me ask it this way. The standard of care does not require there to be a medical administration record in home hospice documentation, true?
I don't know that that's true or false.
You don't know one way or the other.
I don't. I know that if I were the medical director, I would be a little uncomfortable with that, but I don't know either way.
But you don't feel qualified to testify whether it's required under the standard of care one way or the other.
I suppose that's accurate.
Do you feel qualified to testify to the standard of care of a home hospice nurse for actions that occurred in June of 2017?
Only in a very limited way. And that is that, I feel like, and I know this because I've been married to a nurse and my son is a nurse, that a nurse is bound by his or her oath to not carry out an order that they feel would be harmful to a patient.
Other than that, you're not qualified to give standard of care opinions for a home hospice nurse for June of 2017, right?
I think that's correct. I think that's accurate.
In any situation, there could be multiple ways to treat the same patient that would be within the standard of care, right?
I'm so sorry. Please, one more time.
Sure. Do you agree with this statement? In any situation, there may be multiple ways to treat the same patient that would be within the standard of care?
That is not always the case, but it's often the case.
I want to talk a little bit about your record review. I listened earlier when plaintiff's counsel talked about what documents you were provided. My understanding is you were not provided any medical records from Piedmont Athens Regional Medical Center prior to June of 2017. Is that true?
That is true.
You were not provided any pharmacy records prior to June of 2017. Is that also true?
Yes, it is.
And again, I know it's late. I represent several of the defendants in this case. If I asked you to list each defendant, the nurses, could you do that and identify what each one did that was below the standard of care?
No, I could not.
Talking about home hospice, it's true that the goal of hospice is to keep a terminally ill patient comfortable, right?
Yes.
It's to alleviate pain, true?
Yes.
And patients that are in hospice are certified by a physician as expected to live 6 months or less.
Yes.
And of course, that's what a hospice nurse understands when treating a hospice patient, correct?
Yes.
I wanted to make sure, in talking about Dr. Park here, you were asked questions earlier about his affiliation with Homestead Hospice. I think I understand you correctly. You're not sure one way or the other as we sit here today, true?
No, I'm so sorry. Part of it is that I don't hear you that well, but
I'm sorry. I'll speak up. I want to talk about Dr. Park briefly, okay?
yeah,
If I heard you testify earlier, you don't know one way or the other whether Dr. Park was affiliated with Homestead Hospice, true?
I know that he testified that he was not.
Okay. And you have no reason to doubt that, correct?
That's correct.
And speaking with Ms. Couch earlier today, was that at your recommendation or plaintiff's counsel's recommendation?
I know I had questions. I don't remember exactly, but I know that I told plaintiff's counsel that I needed to ask her some stuff.
And when this discussion came up as with Ms. Couch scheduling it within the last week, true?
Yes.
And how long did this discussion take place?
Boy, I don't know. I mean, we've had a couple of discussions.
So
You know,
you're
an hour
asking
here,
about, whoa, object. Are you asking about a discussion with Ms. Couch, right?
Of course, that's what the question is.
Okay. Yeah.
I would never ask you that.
Inquiring about any conversations with me. I mean, it's attorney work product and he's not going to share that.
Okay, let me just re-ask it. Let me make it clear. My understanding is there is an objection that I cannot ask any questions between this witness and plaintiff's counsel because the objection is it's considered work product. Do I understand that correctly?
Yes, that's one portion, correct.
Okay, so let me talk about, we were talking about your conversation with Ms. Couch, the
Yes.
plaintiff. And you said, now it sounds like you've had multiple conversations with her. How many conversations have you had with Ms. Couch?
No, I only had one. I thought you were talking about my conversations with counsel.
Oh, I'm sorry. No, so your conversation with Ms. Couch today, how long did that last?
20 minutes, I think.
And I'm assuming that with Ms. Couch, also plaintiff's counsel attended that telephone conference, true?
Yes.
Did any family members attend that telephone conference?
No.
Anybody else attend that telephone conference?
Not that I know of.
Ask and answer.
And as far as, did you charge for that conversation?
No.
And that's because you were at work at the time and you did not want to, I think you said double dip, right?
Yeah, that's not cool.
Okay. You testified earlier that you read Dr. Park's deposition, correct?
Yes.
Do you agree with him that a patient can be placed on hospice and still live several years beyond the 6 months?
Yes, that can happen. In my experience, though, if the patient lives beyond 6 months, they're referred out of hospice to be referred back in if their clinical condition deteriorates.
Yeah, let me back up. So first of all, you do agree that a hospice patient can live beyond the 6 months, correct?
Yes, it can.
And just because a hospice patient lives beyond the 6 months does not mean the patient was appropriately admitted to hospice, right?
But that's right. My question was not with the fact that she outlived it. It was the diagnoses.
I understand, but we are in agreement at least that if a patient lives beyond the 6 months, that in and of itself does not prove that they were inappropriately admitted to hospice care, right?
Not in and of itself, no.
And typically in a hospice setting, a physician reevaluates the patient and whether that patient should be on hospice periodically, correct?
That's the way it should be, yes.
And typically that happens 2 or 3 months into the hospice care, correct?
I would say so, yes.
And back in your practice of doing hospice work in 2012 and before, you've had patients that have lived beyond the 6 months, correct?
No, I never had any that did.
Are you aware of any of your colleagues that live beyond, any of your colleagues who had patients who lived beyond the 6 months?
I can't think of any. I know it happens, but I can't think of any.
Okay. I just wanted a little clarification. I think I heard you testify earlier today, or at least claim that Ms. Couch was not a candidate for surgery or did not have a clotting disorder, something like that. Are you saying that Ms. Couch did not have a clotting disorder?
I didn't say that, and I also didn't say that she wasn't a candidate for surgery.
No, I understand. I just wanted to make sure. I didn't know if I wrote it down correctly. So you didn't testify that Ms. Couch did not have a clotting disorder. Is that fair?
That's fair, yes.
Let's move to June of 2017. And I know a lot of it's been discussed, so I shouldn't be too long here. You would agree that based on the records you reviewed from Homestead Hospice, the nurses were seeing Ms. Couch almost every day, correct?
That was my impression.
So each time either the registered nurses or the licensed practical nurse went out there, they were laying their hands on her and evaluating her, correct?
I don't know that for a fact, but one would think so. I think they used...
Objection. Go ahead, Dr. Albanese.
Yeah, so I know that Ms. Bonner did a lot of the hands-on, maybe under their supervision or something, but...
Well, is it your understanding that Ms. Bonner was the primary caregiver from June 1st, 2017 through June 26, 2017?
That was my understanding.
As far as her vital signs, did you have an opportunity to look at those in your review?
I did. I don't remember them, though. I don't have that good a memory, but...
Okay. As we sit here today, do you have a memory that any of her vital signs were outside the norm?
I remember an elevated blood pressure. That's about it.
Okay. Now, let's talk about June 26, 2017. At that time, do you understand that Dr. Shiver began to decrease the morphine by 0.05 each dose until the patient was comfortable and not dizzy?
So he was, what was that date again?
June 26th, 2017.
God, I don't remember that. It sounds reasonable.
Okay. And to put it in context, Ms. Couch was early on in her hospice care within the first month. Is that right?
So Ms. Couch was what? I'm sorry?
She was fairly early on in her hospice care. she was within the first month?
The first
correct?
month, yes, that's correct, yeah.
And during this period of time, based on your experience in 2012 and before, that's a time when the physician is adjusting the medications, true?
That should be true throughout the time that they're in hospice, I would think.
So particularly within the first month, correct?
That sounds reasonable.
All right, let's talk about when the EMTs showed up. Well, let me back up a little bit before I get to that. I think you claimed earlier, or you testified, that a stroke, a hospice patient with a stroke does not run a predictable course. Is that correct?
What I said was cerebrovascular disease does not have a predictable course, yes.
And you reevaluate that patient every few months, true?
Yes.
Let's talk about when a hospice patient begins to transition, okay?
Okay.
And when I use the term transition, you understand that to mean passing on or dying, right?
Right, yes.
That's how, in hospice, how they describe a patient's course, correct?
That's how they did it in this case, yes.
Well, that's how they did it back in 2012 too, correct?
Yes.
So when a patient is transitioning, the patient begins to have shallow breathing, correct?
That's correct.
Labored breathing.
Correct.
Patient may groan,
Sure.
moan.
Sure.
Patient may have hallucinations.
Yes.
Patient may have generalized pain,
Yes.
weight loss,
Sure.
difficulty swallowing,
Yes.
difficult to awaken.
Difficulty with what?
To awaken,
Oh, yes. Uh-huh.
erratic sleeping patterns.
I think that's possible, yes.
Loss of appetite,
Yes.
and altered mental status, right?
Yes. Uh-huh.
In your review of this case, did you have an opportunity to review the EMT's depositions?
Yes, I did.
And when they arrived, they were able to speak with Ms. Couch, correct?
That's right.
So at least as of the time the EMTs arrived, she was not, as you described, in a comatose state, correct?
She was, she had altered mental status. I remember that.
Right. But you can't be comatose and talking at the same time, correct?
That's correct. You can be, I think you can be obtunded, you know, you can be, you can have a waxing and waning of consciousness, but yeah, you can't be in a coma and talking at the same time.
So you agree then, as of the time the EMTs arrived, Ms. Couch was not in a drug-induced comatose state, correct?
If she's talking, she's not in a coma. That's as far as I'll go.
And she was, the EMTs also were evaluating her for a UTI due to the odor of her urine, correct?
I remember mention of that, yes.
Okay. You agree that Enterococcus is a bacteria that is associated with the urinary tract infection.
Yes.
You would agree with a white blood cell count of 97 as being consistent with the urinary tract infection.
The white blood cell count in the blood or the urine?
In the blood.
97. Yeah, that's a leukemoid reaction. You know, gosh, a white count that high is really unusual. I mean, so yes, it could be caused by an infection, but infections usually don't cause white counts that high. It's interesting.
Well, so let me ask you this way then. A white blood cell count in the urine of 97, that is consistent with a urinary tract infection. True?
Yeah, it is, yes.
And to treat a urinary tract infection, you prescribe antibiotics.
Correct.
And that typically, takes care of the urinary tract infection over a period of time.
That's correct.
Going back to your claim earlier that Ms. Couch was in a drug-induced coma, if that was the case, you would expect Narcan to be administered, correct?
That's correct.
And if Narcan was not administered, you would be critical of the medical provider.
So I think what you're getting at is that she went to the hospital and there was apparently not given Narcan or midazolam. The thing is that, the doctors there use that term, drug-induced coma. So they must have, I didn't see her, they must have had a reason for using that diagnosis.
There's nowhere in the Piedmont Athens Medical Center records that uses the term drug-induced coma, correct?
Well, they mentioned that she was overdosed.
Okay. My question, however, is there's nowhere in the Piedmont Athens Regional Medical Center records that state that Ms. Couch was in a drug-induced coma, correct?
I thought I saw that, so I can't say for sure. I assume that because you're asking me that it was not, in fact, in the record that they used that term. But for some reason, I had the impression that she was in a coma or was intunded.
That's because Mr. Potts told you that she was in a drug-induced coma.
Objection
Not from the
to
records,
question. You're not to discuss anything that we discussed or anything that regarding my work product or mental impressions. All you are to testify about is what you relied on in formulating your opinion.
Yeah,
And
I use the term.
I'm gonna hold on. I'm gonna object to that, and he's not talking about.
All right. Well, let me ask it a different way. If there's no phrase drug-induced coma in the Piedmont Athens Regional Medical Center, you must have obtained that information or that statement from another source, correct?
Yes, that is possible.
In your review of this case, did you rule out a urinary tract infection for Ms. Couch at Piedmont Athens Regional Medical Center?
I think her labs were consistent with a urinary tract infection.
And you can say to a reasonable degree of medical certainty that at the time Ms. Couch presented to Piedmont Athens Regional, she did have a urinary tract infection, correct?
Yes, I think that's correct.
And a urinary tract infection can cause altered mental status, right?
It can.
Particularly in an elderly patient, true?
True, that's true.
A urinary tract infection can also cause dehydration, correct?
That's correct.
And a urinary tract infection can also cause a patient, strike that. I want to talk about Ms. Couch's current condition. You're not aware of any complications that she has sustained as a result of the events of June of 2016, correct?
Yes, but in my conversation with her today, I was concerned about some post-traumatic stress.
Okay. You cannot state to a reasonable degree of medical certainty that Ms. Couch has post-traumatic stress, correct?
I did not do a formal examination, no, but I suspect she does.
Okay, but as we sit here today, you are not testifying to a reasonable degree of medical certainty that Ms. Couch has post-traumatic stress from the events of June of 2017, correct?
Yes, I was just answering your question. You wanted me to say that she had no sequelae, and I can't say that with any certainty.
Okay, let me be clear for the record then. I understand what you're saying, but as we sit here today, you are not testifying to a reasonable degree of medical certainty that Ms. Couch suffers or has in any way post-traumatic stress disorder from June of 2017.
Object form of the question, it's already been asked and answered. Also object on the basis it's an improper compound question.
You can answer it, Doctor.
So you're asking me to say that she does not have it, and I can't say that.
No, that's not my question. Let me either re-ask it or ask it differently. You cannot state to a reasonable degree of medical certainty that Ms. Couch has post-traumatic stress as a result of the events of June of 2017.
Yeah, okay, yes, I agree with that.
And you agree that Ms. Couch does not have neuroleptic malignant syndrome, right?
That's correct.
So as we sit here today, you were not aware of any future complications that Ms. Couch may sustain as a result of the events in June of 2017 to a reasonable degree of medical certainty.
I cannot say that I cannot say that she certainly has sequelae.
You cannot say to a reasonable degree of medical certainty that she's going to have future complications as a result of the events of June of 2017, right?
Next form of the question, you've asked that question and he's answered it a couple of times now.
You may answer.
You know, I think it's, what I can say is I am not certain that she has sequelae. I think that's the closest I can come to answering the question.
And that's a bit different. I'm saying you cannot state to a reasonable degree of medical certainty that she's going to have complications, right?
Object form of the question is already
Yeah,
answered.
I don't think I can say yes to that.
Okay. I want to talk a little bit about your review in this case and retention by Mr. Potts. You've worked for Mr. Potts, plaintiff's counsel, in this case before, correct?
In this case,
well, not in this. Plaintiff's counsel in this case is Mr. Potts. You understand that, right?
yes, yes.
You've worked for him.
I reviewed the case for him a couple of years ago, I think.
Okay. And you've reviewed at least 2 cases for him in the past, correct?
Just this one and one other one.
And when plaintiff's counsel contacted you, you understood that he was representing the plaintiff in this lawsuit.
Yes.
And what do you bill for your time to review medical records?
You know, I don't have a set rate. The reality is that, you know, he just sends me money, you know? So, I mean, I don't enter into any of this with any expectation of anything. When I, you know, so I, you know, I don't have a rate. I just don't. So.
How much money has plaintiff's counsel sent you so far?
Well, I think $6,500 total, you know, but I never told him how much I wanted, you know. But,
and how much? So you don't know how much he's going to send you for your deposition time today? I'm sorry, you want to testify.
Yeah, I'm not getting paid for today.
Okay.
And this is really painful. So,
okay.
Anyway.
And just to be clear, you have reviewed no records prior to May of 2017 from Ms. Couch, right?
I sincerely believe I have not. No, I haven't.
In the last year, how much income have you derived or earned from doing medical legal work like this?
Just this.
Okay.
I was asked to testify. As a matter of fact, last year we had a patient that fell at our hospital, and that patient sued the hospital. And you know, I was asked to testify. I was asked to tell what I remembered of that. And I got paid something, I think it was $800 or something like that. That was something that I had to do that because I was the first doctor on the scene, you know. But I don't do this as a matter of course. The only time I've ever done this is the one other case for counsel, and then the thing I just mentioned. You know, we're testifying, doing a deposition about what I observed at St. Helena Hospital.
And so you have no invoices that set out the amount of time you spent on this case, correct?
That's correct.
And you have no idea about Ms. Couch's history of taking any types of medications prior to May of 2017, right?
No, I don't think so. I mean, you know, I saw some, well, go ahead with your questions.
That was actually my last question.
Oh, okay.
But I do reserve my right to redepose this witness based on the pending motion. But thank you for your time.
Thank you.
Dr. Albanese, my name is Rolf Martin. I represent Renee Bonner. Do you need a break?
Maybe just a quick one.
Okay, let's take a few minutes. Okay?
Just a quick one.
The time is 10:14 p.m. We are off video record. The time is 10:21 p.m. We are back on video record.
Dr. Albanese, my name is Rolf Martin. I don't have nearly as many questions for you, but we just took a break at your request, correct?
Yes.
And we've allowed you to take a break whenever you felt like you needed one or whenever you asked for one, correct?
My understanding is that if I needed one and I asked for one, that it would be, yeah.
Okay, and we've been polite to you during this deposition. There's been a little bit of arguing among the lawyers, but no arguing with you, true?
Yeah. I mean, you know, whenever I get cross-examined, I feel like I'm getting punched. But I know.
But we punched you in a very polite fashion. Would you agree with that?
Right.
Would you agree?
In a deferential manner, yeah.
Okay. And mention was made of the late hour. Here, it's 10:22 p.m., but you're testifying from California, and so it's only 7:22 p.m. where you are, right?
Yeah, you know, I didn't mean to whine at you guys about that. I mean, you know.
Okay. You understand that Renee Bonner, the lady that I represent, is Miss Couch's daughter, correct?
Yes.
And you understand she's not a doctor, she's not a nurse, she's not a medical professional in any way.
Yes.
All right. It's not unusual for family members to be involved in caring for their loved ones while in hospice, true?
That's true.
Including supporting their loved ones and assisting them in taking prescribed medications, right?
Yes, that's correct.
There's nothing wrong with Renee Bonner or the other family members administering medications as prescribed by medical providers to Ms. Couch, true?
True.
All right. Let me, at one point, you seem to suggest that Ms. Couch got 600 milligram equivalents of morphine in one 24-hour period.
Object to the question that mischaracterizes Dr. Albanese's testimony.
Yeah, so to answer your question, I don't think she ever got 600. I think she could have gotten 600. I believe in good faith that she got as much as 450.
Okay. You also told us that 50 to 100 milligram equivalents of morphine is a lethal dose, right?
It's a potentially lethal dose. People do die who are opioid tolerant at those dosages, yes, according to Dunn's article in 2010.
Okay. If someone is opioid tolerant, it takes a higher dose to be a lethal dose for that patient, correct?
That's generally true, but the patients in this article were opioid tolerant and they were dying at 100 milligrams a day. There was an 8-fold increase in the rates of death.
Okay, so Are you telling a jury that Miss Couch got 450 milligram equivalents of morphine in one 24-hour period?
That's my understanding. That is what I believe to be the case.
That is a lethal dose, correct?
It is a potentially lethal dose, yes.
Okay. So you're saying it wasn't enough to kill her because obviously she didn't die if she got 450 milliequivalents of morphine.
Milligrams equivalents of, yeah, I mean, you would expect that she would have altered mental status, and I believe that's the most likely reason she did. Now, all of those patients who got 100 milligrams did not die. But I think if you're going to subject someone to that kind of risk, they need to have that understanding that you're going to be treating them with medications that could kill them faster than their disease.
Okay. If your opinion is that she got 450 milligram equivalents of morphine in one 24-hour period and it was not lethal to her, would that suggest that she's morphine or opioid tolerant?
It could. However, as far as I could tell, she'd only had trivial exposures in the previous month. Not everybody is going to be exactly the same. I'm not saying that everyone who gets 450 is going to die of 450, but I think the risk is what most people would consider to be unacceptable.
Okay. Let's talk about some of the terms that have been used here today. And as a medical clinician, you know the importance of being very specific when using particular medical terms, don't you?
Yes.
All right. You understand that there is a difference between someone who has altered mental status versus someone who is in a coma.
Yes.
You understand that abtundation, I don't even know if that's the right word, but a patient who is obtunded means that they have a dulled or reduced level of alertness. That's the definition, correct?
Yes. And that was the term I was using, obtundation. I felt that was more accurate.
Because coma is not accurate, is it?
No, I don't think so. I don't think it's accurate. If it wasn't in the discharge summary, for some reason I got it in my head that it was, but if it wasn't in the discharge summaries from, what was the name of that hospital?
Piedmont, Athens.
Athens, yeah.
Athens, Piedmont
Right.
Hospital.
Right.
Because coma is medically defined as a deep state of unconsciousness, correct?
Yes. Now,
Go ahead.
well, the other thing too is that, people who are in a drug-induced obtundation or stupor, they can have different levels of awareness over time. So it may have looked like a coma at one point, but I think obtundation is a more accurate term.
Okay, well, let me explore that a little bit more, because you know that before she went to the hospital on June 26, 2017, that various people were at her house. There was an EMS team that came out and examined her, and she was conversant and conscious at that time, correct?
I know that she did interact with them, yes.
I'm sorry, say that again?
I know that she interacted with them, yes.
Okay. And so regardless of whether or not she was sedated, she was not in a coma when she was at the home before she went to the hospital. True?
So what confused me was the apparent need to get her seen by a doctor. So there must have been some dramatic change in consciousness or level of arousal. But coma, if she, as someone else pointed out, coma is incompatible with verbal communication.
Okay. She was able to converse, and so she was not in a coma during the period of time when she's at home and she's able to converse. True?
True.
All right. And then EMS picks her up to take her to the hospital, and you're aware that they did a Glasgow coma scale on her.
Yes, that's routine.
Okay, and you're familiar with the Glasgow Coma Scale.
Yes,
The fact that somebody does a Glasgow Coma Scale does not imply that the patient is in a coma, right?
No, it doesn't apply depending on the score, you know.
That's right. You and I right now have Glasgow Coma Scales, but we're not in a coma, right?
That's probably truer of you than me, but yeah.
And you say that as a joke. You and I right now have Glasgow Coma Scales of 15, right?
Yeah, that's right.
And that means completely normal level of mentation,
Right.
normal level of alertness and consciousness, right?
Uh-huh.
Able to move our limbs, able to follow commands, able to carry on a conversation, right?
Yes.
Okay, what was her Glasgow Coma Scale when the EMS team monitored it and documented it when they were taking her to the hospital?
I'm sorry, I don't remember. What do you have?
I'll tell you, it was 11 according to the EMS records.
Okay.
A person with a Glasgow Coma Scale of 11 is by definition not in a comatose state. True?
I believe that to be true, yes.
Because you have to get down as low as an 8 to be considered in a coma, right?
Yeah, I mean, that sounds right. Yeah, I don't use it that much, you know, the Glasgow Coma Scale, but yeah, that sounds right.
Okay, so we know she wasn't in a coma at home. She wasn't in a coma when EMS was taking her to the hospital. You said you reviewed in detail the Piedmont Athens Hospital record, right?
I mean, to my satisfaction, yes.
You know that when she was evaluated by the emergency room physician, she was not in a coma, true?
Yeah, I thought, like I said, I thought obtundation was a more accurate term.
Okay. Obtundation meaning a decreased level of alertness.
That's right.
Okay. So that's what she had rather than a coma, right?
That's correct.
And she didn't get worse at the hospital and go into a coma after admission, did she?
No, that's I guess why they didn't use they didn't feel the need to use any reversal agents.
Okay. So at no point while she was in the hospital for this 5-day hospitalization was she in a drug-induced coma, true?
That's I think accurate. Again, they felt that she was overdosed on medication. But I think, coma is probably too strong.
Okay. Well, then, Dr. Albanese, in the 31 times that Mr. Potts had you agree, absolutely certain of your opinions, that she was in a drug-induced coma because of something the defendants did, why did you not disagree with him or correct him during this deposition?
You know, that's a good point, but I believe I did describe it as obtunded. Okay. I believe I used the word obtunded, but I mean, that's correct. I mean,
Dr. Albanese, I sat here and counted them. 31 times he asked you if to a reasonable degree of medical certainty, the actions of these defendants caused Ms. Couch to be drug overdosed and in a drug-induced coma so that she had to be admitted to the hospital. And you agreed with him every time during that 2.5-hour deposition that he took of you, didn't you?
Yeah, so, I was focusing on the wrong thing. I was focusing on cause and effect. Rather than the terminology we were using.
Okay.
So I was focusing on, was this the cause of this change? So that was my mistake.
All right. So going forward, you would agree that it is inaccurate and improper to describe Ms. Couch as being in a drug-induced coma during the time she was at the hospital in June of 2017.
I mean, I think that's accurate. I think, I think that's accurate.
The statement I just made is accurate, not the statement that Mr. Potts made.
Yes, but again, I was focusing on cause and effect. I felt like he was asking me was her being brought to the emergency room, caused by the medications. He never asked me to define what I understood her level of consciousness to be. So he didn't ask me to define her as comatose, So I was focusing on, cause and effect.
One last issue, kind of along the same lines. Were you aware that Julie Phillips, who happens to be the coroner for Madison County, visited Ms. Couch in the hospital on June 28th?
I don't remember that, but
okay. Were you not provided with a narrative written by Julie Phillips, the coroner, regarding her witnessing various conversations, various events, and her visitation to Ms. Couch on June 28th?
I vaguely remember that, so I believe I was provided it, but, I have read over 1,000 pages of information, and I just don't have the kind of brain that can recall all of those details,
Fair enough.
Focus on,
Fair enough. And this is something that included in the pretrial order that Mr. Potts just filed with the court, includes an exhibit that's going to be tendered. So let me read something to you just to see if it refreshes your recollection of whether or not you have reviewed these documents as part of your review of the case. June 28th, 2017, I went to Piedmont Athens Regional Medical Center to visit Mrs. Shirley Couch and check on her condition. Mrs. Couch was in a regular room, sitting up and talking to visitors. She and I talked about cooking various vegetables, parentheses, fried squash, fried okra, cream corn, and pork chop in parentheses. She was very alert and oriented my questions and statements to her. Do you remember being provided that document by Mr. Potts as part of your review of this significant case?
I believe I probably was, but now that you read it, I'm reading about vegetables, and I'm like, I don't think I need to remember this, so.
Okay. But that's absolute evidence that she's not in a drug-induced coma on June 28th, 2017 while she's in the hospital. Agreed?
Well, yeah, certainly you can't be comatose and have that conversation.
The picture, exhibit number 4 that Mr. Potts put up on the screen to compare to an earlier photo, you remember that during his direct examination of you?
Yes,
You have no idea whether she was asleep, unconscious, or blinking so that her eyes were closed in that photo, do you?
Well, that's always the case, it's just a snapshot. It's not a video.
That's right.
Objection. Go ahead, Dr. Albanese. You can finish answering the question.
And I apologize.
Finish answering the question.
Yes, certainly. I apologize, Doctor. Please finish. I just didn't think, I thought you were finished. Go ahead.
Yeah, I think, it's a legitimate point. I think what I saw was someone who looked obtunded, and I think she had oral suction tube, which, suggests that she's not alert, so anyway, I think there's evidence from the picture that she's not alert, but, just a snapshot, you can't tell for sure.
Okay, because that would require actually an examination at the time, right?
Yeah, a video of someone trying to arouse her.
Okay, and you don't have that. So you don't know whether she was asleep, unconscious, or simply had her eyes closed when the photo was snapped, right?
Well, that's definitely the case. You can't be sure.
You're not going to come in to court. Let's assume that you actually come testify at the trial of this case at some point. You're not going to come say, oh, she must have been in a coma because of that photo. That's not enough for you to say she was in a coma, right?
No, it's not.
And all the other information in the medical record that you were provided to review indicates that she was never in a drug-induced coma. Accurate?
Yes, I think she was obtunded. I think she had altered mental status, but coma, I think, is not necessarily accurate.
It's an exaggeration to say that she was in a drug-induced coma. True?
I only want to go so far as to say probably not accurate.
Okay. It's untrue to say that she was in a drug-induced coma, right?
I'm willing to say inaccurate, but nothing more.
Why is that? Because you know Mr. Potts has got himself in a pickle by using that term?
Well, no, because, you know, in medicine, inaccurate is about as strong a term as I ever want to use, you know? I mean, there are adjectives that you use in medicine, like, you know, like, for example, if a patient is lying to me, and I know he's lying to me, I might say he gave me inaccurate history, you know, or if a family member is confused, I might say that they're giving me inaccurate history. I'm not making a value judgment. You know, I don't think that's something that I don't do as a physician. I just say accurate or inaccurate, relatively accurate, relatively inaccurate.
I'm almost done, Dr. Albanese. So several times you mentioned, coincidentally, just like another expert hired by Mr. Potts mentioned, that you were absolutely certain of your opinions. Are you absolutely certain of the opinion that Ms. Couch was not in a drug-induced coma?
Objective, woman, the question.
No, I'm not absolutely certain. I'm confident that she wasn't. I'm willing to say that much.
Fair enough. All right. It was nice meeting you. I appreciate your time.
Okay, thank you.
Madam Court Reporter, what exhibit? Is it number 10?
I believe so. I think 9 was the last one I have.
Dr. Albanese, if Dr. Gina Singh told Shirley Couch that she was in a drug-induced coma, Dr. Gina Singh being the physician that cared for her and the physician that's board certified in internal medicine, would you defer to her for that diagnosis?
Objection here.
Objection.
Join.
Yes, I would.
Yeah. And is that because Dr. Singh is board certified in internal medicine?
Well, that and she was there. I mean, she was physically present, you know, and evaluated the patient. And I think that's probably the most important thing.
Yes, sir. And if Dr. Gina Singh, who I think had 13 years experience at the time, if she told Shirley Couch that she was in a drug-induced coma, would there be any reason for Shirley Couch to think that Dr. Gina Singh was lying?
Objection.
Join.
You may answer.
I don't think so.
Yeah, would there be any reason for her family? Christy Carr, Paula Stuchel, and others who Dr. Gina Singh also told that their mother, Shirley Couch, was in a drug-induced coma. Any reason to believe that Dr. Singh was lying to her family members about her diagnosis?
Objection.
Objection, and also
You may answer.
That's an improper question to ask a witness, especially an
You may
expert
answer.
witness. I'm sorry, I wasn't quite done, Mr. Potts.
You may answer, Dr. Albanese.
I'm sorry, I wasn't quite done with my objection, Mr. Potts. I'm objecting to asking this witness to comment on the credibility of other witnesses.
You may answer, Dr. Albanese.
You know, I think I don't see why they would exaggerate that.
Right. Well, any reason Dr. Singh would lie?
No.
Same objection.
Objection.
What reasons would Dr. Singh lie to a Georgia Bureau of Investigation agent?
Objection.
Objection.
Join.
You may answer.
None whatsoever.
Yeah. Is there a California Bureau of Investigation?
There must be. I don't know.
Yeah. Any reason to believe that the investigators, in fact, the senior agents of the California Bureau of Investigation are liars?
Objection.
And Mr. Martin suggested to you that I was lying because I said Dr. Gina Singh diagnosed her to be in a drug-induced coma. Is that what Mr. Martin suggested to you?
Objection. I never called you
You
a
may
liar,
answer.
Mr. Potts. That's simply inaccurate.
You may answer, Dr. Albanese.
I felt like Mr. Martin was calling your integrity into question.
Yeah. And if she was in fact, Shirley Couch was diagnosed to be in a drug-induced coma by Gina Singh, that would mean that Mr. Martin was lying when he told you that 31 times there was no evidence and no basis for your testimony. Wouldn't that mean Mr. Martin was lying?
Objection.
You may answer, Dr. Albanese.
I don't think anybody's lying here. I think people are following their interest, So, I'm not accusing anyone of lying. I think the problem with this is that I get asked yes or no questions, and the yes or no questions are not, I believe that this patient was harmed by the use of medications that, and at dosages that were potentially, lethal. They didn't kill her, and maybe they didn't put her in a coma, maybe they did, but
Yes, sir.
that's what I think is the main issue here. I think this patient was harmed, and that's how I feel about it.
And I'm going to object.
So you understand that?
Hold on, James. I'm objecting to that being non-responsive to the question.
You understand that Mr. Martin also has access to the Georgia Bureau of Investigation, their investigation in this case?
Objection. He has no clue what I have access to, Jim, so I can't imagine why.
Any reason to believe he doesn't?
Irrelevant.
Well, it would be, I don't know, doesn't everybody have to have access to the same stuff? The Brady,
That's right.
whatever,
Access to that.
I'm going to show you what's been previously marked as Exhibit 10. And this is where Georgia Bureau of Investigation agent Hartzog interviewed Dr. Singh, Dr. Gina Singh, the board certified internal medicine physician who made the diagnosis, as well as Shirley Couch and her family members. And she noted and wrote that Dr. Gina Singh told her family that Couch was in a, can you read those next three words, please, Dr. Albanese? Can you see that all right? I can make it bigger. Mr. Video.
Coma.
You see, would you read it again, please?
Drug-induced coma.
Yes, sir. And does that mean that Mr. Martin, when he said that she was not in a drug-induced coma, was lying?
Objection.
You may answer. He's trying to get you to lie too.
Objection.
You may answer, Dr. Albanese.
Go out on that limb.
I mean, I think, that there's evidence for coma. Maybe there's evidence not for coma. I think that what I saw was consistent with obtundation, and I don't think there's a whole lot of difference really. I think if a person's obtunded because of the medications they're taking, that's bad too.
Yes, sir.
So I think there's evidence for and against, so.
Yeah, but you agree with your original testimony that the amount of drugs she was prescribed by Dr. Shiver and administered by the defendant nurses and his client, Ms. Bonner, was plenty to put her in a drug-induced coma, right?
Yeah, it was sufficient to do that.
More than sufficient. It was sufficient to kill her.
Yeah.
And so either Dr. Gina Singh and Dr. Patricia Highback and Shirley Couch and Christy Carr and Paula Stuchel, and I'm lying, or Mr. Martin's lying. Is that right?
Object to the form.
You may answer.
Man, I see what you're saying, you know, but I think to accuse each other of lying, this is disturbing. I find this disturbing.
I understand. I agree. Your original testimony when you testified, according to Mr. Martin's math, 31 times, that to a reasonable degree of medical certainty and beyond that absolutely certain, when you testified as to her drug-induced coma based on Dr. Gina Singh's diagnosis, that was accurate.
Objection.
Yeah,
Same objection.
You may answer, Dr. Albanese.
I never got asked, you know, was there no evidence ever of any coma? I had remembered seeing that somewhere. I didn't remember exactly where, but, you know, I think we're focusing on the wrong thing here. You know, coma or obtundation are both bad, you know.
Well, you agree that if Dr. Singh diagnosed her to be in a drug-induced coma, she was in a drug-induced coma.
Yeah, if that's what she,
Objection.
You may answer.
I mean, if that's what she told the SBI, I think that you know, you have to take that into consideration. You can't disregard it.
And earlier, you were talking about the black box warnings for all the opioids involved in this case. Is that right?
Yes, all opioids have a warning of respiratory depression and death.
That includes the fentanyl, the morphine sulfate, the hydrocodone, and the tramadol, right?
Yeah, and as a matter of fact, almost all state boards now require us to do extensive training on the dangers of opioids nowadays to keep our licenses active.
Yes, sir.
Up to date.
And those are the Federal Drug Administration's black box warnings. Is that right?
You know, I don't know who actually composes them, but they require the pharmaceutical companies to make them available.
Right. And so it's a package insert where the drug company, in compliance with the FDA, is required to have those black box warnings. Is that right?
That's correct. I use Hippocrates, which is a digital pharmacopoeia, and it has a section on black box warnings, and you just click on that, and it tells you what the black box warning is for that medication.
Yes, sir. And you use the black box warnings when you prescribe drugs?
Yes, absolutely.
And you still use them?
So let me think. I inherited several patients here at the Veterans Home who were on opioids, and they were also on benzodiazepines. So the patient was already on a benzo and an opioid. So in every case, what I do is I explain to the patient that this is potentially dangerous and could kill them. And that if I recommend going off of it. If they feel like they don't want to do that, then I'll say, okay, fine, I'll continue to prescribe this, provided that you don't have any of these problems. You don't wind up in the emergency room with altered mental status. You don't wind up in the emergency room with respiratory depression. You don't have falls. So I go through all of it with them and make sure I get informed consent, and I document that. And then, like I said, if they do have any of those problems, then I tell them you're going to have to come off of this. So I don't start benzos ever on a patient who's on opioids. like I said, I've inherited some patients, and if I can't convince them that it's in their best interest to come off of it, then I just give them the warnings and say, now, if these things happen, you're coming off of it, whether you want to or not.
Now, those black box warning, is there proviso in the warnings that says you can ignore this warning when you're caring for a hospice patient?
No, and I think if you're going to expose a hospice patient, now obviously, the goal in hospice is not to cure, it's to make a person comfortable. And so sometimes that requires a slightly different perspective on how you prescribe. But if you're going to prescribe someone dosages of medications that are potentially lethal, I think that needs to be clearly documented, that you explain that to the patient so that the patient has a choice to say, well, I don't want to take that risk. You're going to have to underdose me if that's the case. So I don't think just because they're a hospice patient doesn't mean that we can be reckless. I think it means we can be generous, but I don't think it means we can be reckless.
So the black box warnings, in other words, they still apply in a hospice setting, right?
Yes, they do. And as as far as I know, it's not the standard in most states to say, well, in order for us to stop your suffering, we're going to have to make you stop breathing.
And
that would be physician-assisted suicide or euthanasia.
Yes, sir. And when I got another question for you, does the chemistry of morphine sulfate, is it different in a hospice setting than it is in a patient outside the hospice setting?
I mean, I would, if the patient is debilitated, I would think some patients who are debilitated and immobile, they will have a slightly longer half-life than it would in someone who's ambulatory. Otherwise, I wouldn't say so.
So chemistry is the same. Morphine sulfate is morphine sulfate, whether the patient's under hospice care or under a hospital care or under an orthopedics care and not in a, okay.
Objection leading.
Same thing for fentanyl. Is fentanyl, is that drug any different in a hospice setting and outside of a hospice setting?
No, I don't. Foundation qualifications.
Is the drugs the same?
Yeah, I think so. Yes, I think.
Are the patches the same whether they're on a patient that's in hospice care or a patient outside hospice care?
They would be the same. Yeah.
Is there do they give a different patch for a hospice patient?
No.
Oh, okay. And what about hydrocodone? Is that hydrocodone the same that's used in a hospice setting? Is that the same hydrocodone they use everywhere else outside the hospice setting?
Yes.
And do the same black box warnings and rules based on your education, training, and experience about diagnosing a patient, having a reason for the drug, properly administering the drug, knowing what the drug is, what it does, what the contraindications are, and what the potential adverse effects are all those required inside and outside a hospice setting?
Compound question.
You may answer.
Yes.
Any difference at all?
I'm trying to think. I mean, hospice patients are different in some ways. Like, for example, I might say to a patient, look, I can get your pain under control, but you're going to be sleeping most of the time. Some hospice patients are going to say, well, that's okay. And I'm not talking about obtundation here. I'm talking about this mild sedation. Some hospice patients are going to say, no, I'd rather be awake, So there are some slight differences, but it's just because a patient's in hospice doesn't mean that we can be so cavalier with the medications that we actually, cause their status to deteriorate, that I think there are some theories and some, like, for example, euthanasia, and physician-assisted suicide that kind of think that way, but that's only in a few states that they have that. I'm sure Georgia isn't one of them. I don't think we have that here in California either. You can't say because you're dying anyway, we're gonna, put you out of your misery. I mean, that is not a generally accepted approach.
Mm-hmm. Now, is haloperidol, is that drug any different inside or outside the hospice setting?
No. I mean, in the hospice setting, I think the rationale for use is extremely weak. If you're in an inpatient psych setting, of course, that's different. You're going to use high dosages, you're going to dose aggressively. So, I mean, it's, the patient needs to be psychotic if you're going to give them an antipsychotic.
Right. Now, haloperidol, that's an antipsychotic drug, right?
Uh-huh.
That's a psychotropic drug.
Yes.
And is that prescribed by anyone other than a psychiatrist like yourself?
I mean, obviously it can be.
Right. But psychiatrist, if it's a psychotropic drug, that would be prescribed by a psychiatrist nearly all the time.
Yeah, I think the vast majority of the time, and ideally, yes.
Well, like 90, 95%? What's your best
I
estimate?
would say 90.
Action leading.
You may answer. What's your best estimate?
90, 95%, yes.
So, as a board certified internal medicine and a psychiatrist, one of the drugs here, haloperidol, there wouldn't be anybody who's not a psychiatrist who would know more about how to properly diagnose, prescribe, and administer that drug. Is that right?
Psychiatrist would be the acknowledged expert in the use of.
Would be the best. Is that
Yeah.
right? And that's those benzodiazepines. Those are also psychotropic drugs. True.
Yes, they are.
And those would be prescribed by psychiatrists too. About what percent of the time?
Well, unfortunately, I think about 50% of the time. A lot of primary care doctors use them, and a lot of the patients I have that I don't think are on them appropriately were prescribed by non-psychiatrists.
Yes, sir. You agree that a psychiatrist would be, again, the best to testify regarding, the proper diagnosis, use, and administration of benzodiazepines like the two in this case?
Yes.
Objection leading.
Psychiatrist would be the acknowledged expert in the prescribing. The psychiatrist would be the acknowledged expert in the prescribing of benzodiazepines.
So who would be the acknowledged expert in prescribing of benzodiazepines? What specialty?
Psychiatrist.
And who would be the expert in the prescribing of haloperidol?
Psychiatrist.
All right. And what about opioids? Are opioids a psychotropic drug?
They have been used in psychiatry to treat disorders such as depression. I think psychiatrists are more experts on the abuse of opioids. We do a lot of addiction treatment. I have a lot of experience in treating addictions. I think people who are experts in the use of opioids to treat pain would be pain management specialists. But we do treat pain. Psychiatrists do treat pain with opioids, but mostly we treat addiction. And I think we have a lot of expertise in the downsides of opioid use, overdose and addiction abuse.
So who better than a psychiatrist to testify about opioids, if anyone?
I think that we are among a group of professionals that have expertise in that field.
Yes, sir. Now, you were talking earlier about, you were asked about patients being admitted to hospice and living past the 6 months, have you had a hospice patient to live 5, 6 years or longer in
No.
hospice? Okay.
No,
I believe you testified too that, was Shirley Couch a hospice appropriate patient?
no, and although the fact that she is still alive is not proof that she was hospice inappropriate, but it certainly does support that contention.
You were also asked about Shirley Couch's vital signs. Is it true that a patient like Shirley Couch can be given the amount of drugs here, opioids, opioid equivalents, benzodiazepines, and an antipsychotic drug, and still have a respiratory rate within normal limits?
Yes, it's possible. It's certainly possible. I think the fact that she survived as much as she was given suggests that, she has maybe some ability for whatever reason to metabolize it more quickly. But it is possible, yes.
And the supplemental oxygen, could that have played a role in that as well?
Yes, so as I recall, they were monitoring her oxygen saturation, and if you give supplemental oxygen, that will make the oxygenation look normal when without it, it wouldn't be. If someone's hypoventilating, if someone's breathing inadequately because of the opioid.
Yes, sir. So the oxygen supplementation, that could also mask the signs and symptoms of a drug overdose. Is that right?
It could, yes.
Now, you were asked about, you were given a number of signs and symptoms by, I believe it was Mr. Mazziotti. And he gave you those individually and asked you whether those could be a sign or symptom of a certain disease process. Do you remember that?
Urinary tract infection, yeah. But I didn't think that was the most likely cause in this case.
Yes, sir. And isn't it true that a physician, to make a proper diagnosis, you take into account an entire constellation of signs and symptoms, not in isolation? Is that right?
Objection,
Yeah,
lady.
of course.
And the reason for that is what?
Because, any one given symptom, let's say, for example, just as an example, rapid breathing. So that doesn't apply to this case, but somebody can have rapid breathing because of a panic attack. They can have rapid breathing because of a pulmonary embolism. They can have rapid breathing because they're having a myocardial infarction and a number of other things. So you have to figure out which one it is. So you have to take into account things like, what does the electrocardiogram look like? What is the oxygenation? What is the patient's medical history? That kind of thing. So just because they're breathing rapidly doesn't help you make a diagnosis.
Yes, sir. You agree that 450 milligrams of morphine in less than 24 hours can cause an altered mental status?
Absolutely.
Object to form.
Back to Exhibit 10. Let's have a look. I think we were right here last time. You see where it reads drug-induced coma?
Yes.
This is page 7 of 162. And you agree that anyone that suggested to these jurors that a drug-induced coma was in any way false or an exaggeration or untruthful or inaccurate, you agree that that statement by, in this case, Mr. Martin, is indeed false?
Objection.
You may answer.
Inaccurate is as far as I'll go.
All right. You see where it reads drug-induced coma here, though, right?
Yeah. Yeah.
And then a little later in that same paragraph, do you see again this? Can you read those 3 words?
Yeah. Drug-induced coma.
Yeah. So Agent Hartzog also asked McKnight what amount of morphine it would take to make someone overdose or go into a drug-induced coma. Right? You see that? And if we continue on, the same Exhibit 10, now we're up to page 34 of 162. Do you see where Pippin had never heard of anyone going into a drug-induced coma from normal doses of morphine? However, Pippin stated it would not be, Pippin had never had any patients go into a drug-induced coma. Pippin stated it would not be possible for someone to forcibly administer enough morphine to a patient to make them go into a drug-induced coma. Do you see that?
Yes,
Okay.
Object to this line of questioning. Hearsay document.
And you see Agent Hartzog asked Fowler how much morphine it would take to put someone in a drug-induced coma.
Mhm, yeah. Mhm.
And Fowler stated it would require a lot of morphine. Do you see that?
Objection.
Same objection.
And do you agree that 450 milligrams of morphine is a lot of morphine
Yes,
and plenty to put somebody in, quote, a drug, and I'm going to make sure that the jurors can see this, a drug-induced coma?
yes.
All right.
No objection showing something to.
You see, now we're up to page 43 of 162. This is Nurse Allen. How much morphine it would take a patient to overdose and go into a coma? Allen didn't know the amount. Do you think it's important for nurses that are monitoring patients that are being given opioids that they know how much of the drug that they're monitoring it would take to put someone in a coma to be dangerous to that patient?
Objection, misstates testimony, misstates this document. This document is history, is a hearsay. So it'll be excluded, but go ahead.
Objection.
Join.
I think they should have some general idea.
So, see, now we're up to page 55. Do you see those three words again? Drug-induced coma.
Yes,
Agent Hartzog asked Dr. Singh. Now, that's the same Dr. Singh that diagnosed Shirley Couch to be in a drug-induced coma.
yes.
Asked Dr. Singh how much morphine someone would have to consume in order to go into a drug-induced coma. Do you see that?
Yes,
And that's at page 55 of 162 of Exhibit 10.
yeah.
And Dr. Singh stated a good dose or very frequent dose would be enough to overdose someone. Morphine combined with fentanyl patches or other drugs would also have a negative effect.
Yes.
Same objections.
Join.
Join.
Now we're up to page 87. You see this again, drug-induced coma here and
Right.
dehydration. Agent Hartzog advised Bonner that her mother was taken to the hospital on June 26, 2017 and was diagnosed with a drug-induced coma and dehydration. Do you see that?
Yes.
Objection.
Was there any reason for GBI Special Agent Hartzog to lie to Renee Bonner about that?
Objection.
I mean, I could think of any. I mean,
All right. Anything based on your review of the record and the depositions and the exhibits and Agent Hartzog's report and the medical records that suggest that that was inaccurate or untruthful?
Objection.
Same objections.
You may answer.
no, I mean, it's no.
All right. We're back to page 7. And you see this, Dr. Gina Singh told her family that Couch was in a drug-induced coma.
Right.
Right.
Join.
Does that change? I think Mr. Martin suggested to you that that was not the case. Do you now agree that that in fact was the case?
Objection.
Same objection.
I'm confused by the different sources of information. I think what I can say with certainty is that that Ms. Couch had a negative impact on her level of awareness and arousal. Central nervous system was transiently harmed by the amount of opioid that she was given in combination with the other medications, Was it coma? Was it obtundation? They're both bad,
Do you think, Doc, that Mr. Martin was trying to mislead these jurors when he said that there was no diagnosis of drug-induced coma and suggested that you misrepresented that 31 times in your direct examination?
Objection.
You may answer.
Well, so, I knew I had read coma somewhere. I couldn't remember exactly where it was from. So I used that term. I certainly saw it in the GBI report, which I read actually fairly recently.
Yes, sir.
I know, that I guess it's their job to make me look like I don't know what I'm talking about, but, as I said before, when I was agreeing to coma, I know I had seen the word coma in some of the 1,000 or so pages that I had reviewed. But even so, I was focusing on the fact, and I thought you wanted me to focus on the fact that it was the medications that caused this change in this patient. And so that's what I was focusing on. Whether it's coma or obtundation, it's bad.
Right. And I believe Mr. Martin started his questioning by talking about how nice that he'd been to you. Do you think it was nice to try to mislead you about the evidence in this case?
Objection.
It's definitely gloves off.
What? I'm sorry?
It's definitely gloves off.
Ah, yeah. And do you think that's, to try to embarrass someone or suggest that they're lying to these jurors? Do you think that's especially when it's false, when what Mr. Martin told you was utterly false, is a nice thing to do?
Objection.
You may answer.
Is this about niceness? Like I said, it's gloves off. It's gloves off. It's not a gentle line of questioning when someone says, now you inaccurately endorsed this 31 times. But I guess I figured he was doing his job, but
Right.
But my point was we're focusing on the wrong thing,
Yes, sir.
There was a negative change in the patient's medical status, and it was, I'm certain that the medications caused it.
Yes, sir. And the reason the medications or drugs caused it is not because one of those drugs alone would have done that. It was because of the sheer numbers of the drugs that she was given and the amounts of those drugs that she was given.
Objection.
You may answer.
Yeah, I would agree with that. I think the dosages and the combination were the problem.
All right. That's all I have, Dr. Albanese.
Dr. Albanese, I'm going to go first. I have a couple of questions for you to follow up on that issue. Not one of the documents that Mr. Potts just showed you suggesting that there was a drug-induced coma was actually a medical record, was it?
No, and like I said, I couldn't remember where I saw it. Again, I've looked at over 1,000 pages of information, but to me, that's not the appropriate emphasis, is whether or not it was a coma.
I understand that. And you're saying that because she didn't actually have a drug-induced coma, did she?
I mean, if it
Jeff?
wasn't in the discharge summary, then it probably wasn't. I think most likely. However, I think the point is that she was harmed by the medications.
Dr. Albanese, don't you think that if Mr. Potts had a medical record where Dr. Singh said this patient had a drug-induced coma, that he would have shown you that rather than some hearsay statement from a non-medical provider?
Who is asking questions now? Mr. Martin?
Yes, go ahead, Dr. Albanese.
No, you're not. No, or do you not have any questions, Mr. Mazziotti?
Yeah, I'm asking the questions right now. Go ahead, Dr. Albanese.
No, you can't. If Ms. Barnes doesn't have any questions, Mr. Mazziotti doesn't have any questions. Otherwise, you're not permitted to ask questions now.
Well, are you the judge?
Yeah, I know the rules, and we're going to play by the rules.
Fine,
So,
we'll
Ms.
go in
Barnes,
that
do you
order.
have any questions, or Mr. Mazziotti, do you have any questions? You're not up yet, Mr. Martin.
Well, fine. Thank you, Judge Potts.
You're
Go ahead,
welcome.
Tom.
You're welcome.
But actually, Sharonda goes next.
I will go next, and Dr. Albanese, I will be brief with you, and I apologize if you were asked this. It's been a long evening, but you have never served as the medical director of any hospice facility, either at home or inpatient, in your entire career, correct?
That's correct.
Okay, those are the only questions I have. Thank you.
I guess it's my turn now. You would agree that even a single dose of morphine can cause an altered mental status, correct?
Depending on the patient, depending on the situation, it's possible, yes.
So my statement is true, correct?
Yes.
Objection answered, yes.
Okay.
Ask and answer.
With that answer, that's all I have.
So, Dr. Albanese, I'll start where I tried to start just a moment ago, but you were not shown one official medical record that indicated a diagnosis of drug-induced coma. True?
Object to the form of the question.
So all I can say is I remembered seeing it. And since it was in the, I think the SBI report summary, it's not useless information. Now, again, I would rather I think it would be more credible if the discharge summary, the medical documentation said medication-induced coma. But, again, this woman had altered mental status due to the medication. So whether or not she was in a coma, to me, is not as important as that she was harmed by the medications.
Dr. Albanese, with respect to you, I'm going to move to strike the testimony because that's not responsive to my question. So let me try again. And if you'll just answer my question. Mr. Potts did not show you one official medical record that included the diagnosis of, quote, drug-induced coma.
Objection. That question's already been asked and answered. And it's actually been asked and answered repeatedly. Dr. Albanese, you do not have to keep answering the same questions over and over and over.
Go ahead and answer, Dr. Albanese.
So
we all know the answer. Go ahead.
Are you the judge, Mr. Martin? Yeah, you know it because he's already answered it. And you don't get to keep asking him the question just because you don't like the answer.
Go ahead, Dr. Albanese.
I can't say yes or no to that. I mean, all I can say is I remembered seeing it in a document where I thought it was credible. So if you're telling me that it's not in any of the medical documentation, that's very possible, but I know
objection. Go ahead, Dr. Albanese. You can finish answering the question before Mr. Martin can ask.
I think I did already. I think I finished.
All right.
Okay, I'm sorry. I thought you were done as well. If I cut you off, you feel free to tell me. I don't need Mr. Potts yelling at me. So you just tell me, and I'll be glad to let you finish your response. It's a little hard on Zoom to know if people are done. Okay. Yeah. So if Dr. Singh's discharge diagnosis was altered mental status, summing up the hospitalization, that's different than drug-induced coma, true?
It is, but it doesn't rule out that there was a drug-induced coma.
And if ever Ms. Couch was in a drug-induced coma during her hospitalization at Piedmont Athens Hospital, Piedmont Regional Medical Center, that should have been documented in the official hospital record, right?
Object to forming the question.
Yes, I think that's reasonable.
Okay, and it was not. So all you've been given is some hearsay by some non-medical professionals where they're talking about whether or not there was a a medication-induced or drug-induced coma, right?
Object to forming the question.
Okay. So the official medical record does not suggest that Ms. Couch ever suffered from a drug-induced coma. Agreed?
That's correct, but it also does not rule it out.
All right. Thank you. That's all I have. I appreciate your time.
I don't have any additional questions.
The time is 11:26 p.m. This concludes the videotape deposition. We're off video record.
Bonnie, I think everyone here will take our usual orders.